It takes. Sad we missed that. Okay. Got it. Okay. If you are actually following this online, my thanks to all the folks on Align who have very graciously introduced themselves so that we know who you are, because we certainly want to continue to include you. This is going to be a bing, bing, bing day, so I'm not going to keep chatting. I forgot, let's be honest, to really acknowledge Tracy, Hart, and the foundation who've really made this happen for us. And hopefully we're going to lift a lot of boats today and share a lot of knowledge. So with no further ado, I am going to introduce our first speaker, Deb Krakow, who's going to push us forward beyond kiddos to talk to us about women's health issues. Thanks, Deb.
It's really nice to see all of you. I hope that this is just highly interactive because I've just made a few slides, but these are the questions that I get asked frequently taking care of patients with OI. So acknowledge Rashmi Rao. Rashmi Rao is a young OBGYN maternal fetal medicine person who has taken an interest in caring for patients with osteogenesis imperfecta while they're pregnant. And I think one of our goals is really to engage our younger colleagues to continue to be taking care of patients with OI. Okay. Push, push. So when I think about women's health, there's multiple questions that get asked. And one of them is, what about family planning? So I am not going to talk about teenagers or young children. Girls with OI will go through puberty at the same age as their mothers do. So it is not a weight-driven issue. So if there's any questions on that, I'd be happy to talk to you about it. These are the questions that I get often asked. What kind of birth control can I use? So obviously birth control pills are absolutely perfect to use. The dose doesn't have to be adjusted. I've seen people say, well, you only weigh 80 pounds, so take a pill every other day. You don't have to do any of that, just regular birth control pills. You can use IUDs with and without hormones. I think that implants the hormonal implants that get put in here, I think are actually difficult to use if you have rhizomelia, right? So if your arm is normal length, fine. But if there's any concern about fractures or deformity of the upper limb, I would not recommend them. The NuvaRing or vaginal hormones are absolutely safe to use. They can be technically difficult sometimes to put in. Diaphragm is misspelled. It can be difficult. Again, diaphragms can be difficult to use, and obviously permanent sterilization is always an option for individuals. In terms of family planning, the things I talk about is all of us know about OI. We understand the inheritance patterns. We understand the genes. But do you have any other medical problems? And I think that sometimes this is something that gets forgotten about, right? Everyone is so focused on their bone and their OI. And just to remind people that even though the patient has OI, they still can have a child with cystic fibrosis, sickle cell anemia, Tay-Sachs, that there are other genetic conditions that needs to be screened. You have to make sure your patients know their family history, and obviously we tell people to be in their best physical condition, your ideal body weight, ideally off bisphosphonates. Though if somebody is on bisphosphonates and gets pregnant, we never tell them that that's a teratogen. And then obviously optimizing vitamin D levels. It is really amazing how many people don't have optimal vitamin D levels. And most of the calcium that is absorbed into the fetal skeleton in the first and second trimester derives from calcium that is absorbed through the maternal GI tract and is vitamin D dependent. So, these are continued gaps that hopefully all of you will help us understand in the OI community. that historically the medical community has not been always supportive of women with OI getting pregnant, particularly if they have more moderate to severe forms. Even within our community, we have ongoing debates about pregnancy and breastfeeding, because breastfeeding actually is a state where you actually take calcium not from the GI tract, but from the maternal skeleton. And there's just this ongoing debate about what's important. And we continue to study pregnancy complications in women with OI, particularly the milder forms. We published a paper last year showing that women with the milder forms of OI had increased hemorrhage and fractures in pregnancy. It's not a reason not to get pregnant, but it's an important thing to be able to tell the patient. And people have published on fetal outcomes. I'm going to go quickly. There are a lot of maternal changes that happen, and the most important one to me is that your total body water goes from 6.5 to 8.5 liters per minute. If there is any underlying cardiac disease or valvular disease, that's going to be important. We follow the same guidelines that is followed by the American College of Cardiology for predicting maternal outcome. And so it's all really based on ejection fraction. So if your ejection fraction is less than 45% for any reason, then you're going to say you're not going to have a very good pregnancy outcome. Pulmonary changes. All pregnant women complain about being short of breath. Anyone's ever been pregnant in the room, but they're all short of breath in the third trimester, and we all joke around and say you're not going to stop breathing. Your respiratory rate goes up. There's relaxation of the ligaments between the ribs and the sternum, and it makes you feel like you can't catch your breath. So there's this physiologic shortness of breath that occurs in all pregnancy. And then depending on the baseline of your patient, you have to incorporate that into what you think about. Kyphoscoliosis hopefully is becoming less and less of a problem in our community as surgeons start to address. But again, patients who have significant kyphoscoliosis, particularly angles greater than 120 degrees, actually will have problems in pregnancy. In terms of musculoskeletal adaptations, I talked about that the majority of fetal calcium is met through GI absorption and has no consequence except in the third trimester where the resorption is coming from the maternal bone. So again, it's important to have adequate vitamin D and adequate calcium. And so we recommend anywhere from 1,000 to 1,500 milligrams per day. And so I try to keep people at vitamin D levels greater than 32. I don't think that I think Christine, you're here. I don't think that these super high vitamin D levels of 50 to 60 actually improve bone health. You agree? So yeah, but you know, there was a trend where everyone was like getting super high. I don't think there's any evidence. If you have a kyphoscoliosis greater than 25 degrees, we check them every trimester. And just to be aware of back pain in pregnancy, 60% of average stature women complain of back pain in pregnancy. Again, a really common complaint. But just remember that in the OI community, when I hear someone's got worsening back pain, to think about vertebral compression fractures. Transient osteoporosis of the hip is absolutely a medical emergency. And if you look at the literature in pregnancy, all the case reports said the patients either had OI or they had a family history of low bone mass, whatever that means. So again, very, very rare, but needs to be addressed. And I'm not going to talk about delivery. You can ask questions. I think that this is still a really controversial area. Breastfeeding the benefits of breastfeeding for the newborn has been very, very well established. But the question about whether mobilizing calcium away from the maternal skeleton during the period of breastfeeding is worth it. We saw an increase in our survey of 132 women, which I'll talk about later. We saw that 10% had postpartum fractures, mostly vertebral is what they reported. The French group just reported very similar findings and actually suggested not to breastfeed. The Danish group just published and said there's no increased fractures. So again, a very controversial area. General health. Women with OI need to get general health, right? They need to have pap smears when they're sexually active or over 21. If it's every 3 years with a negative, if you've had a previous negative pap smear, please encourage your teenagers to get HPV vaccines. Safe sex practices, flu shots, COVID shots, mammograms based on family history. If somebody cannot fit, the mammogram machines now are getting better and better about going lower and lower and lower. But if they can't, then I recommend breast ultrasound, and if absolutely necessary, breast MRI, colonoscopy, if possible after 50. And obviously, I think at every provider visit, when someone comes to me for GYN, I always talk about safety at home and safety in relationships. What I've come to learn is just because you have OI, all the other issues that affect women in terms of physical harm still can happen. And I think that we get so focused on bone, which is, I love bone and cartilage, but that we have to remember these things. So menopause and health. You know, menopause is a midlife event, and it is also coinciding with your children's needs, your parents' needs. And it is happening at a time when women are being kind of squeezed between two generations. And I think we have to take that into consideration. It's really interesting. The majority of patients don't seek help for menopause. There's conflicting data, and physicians really don't have time to sit and talk about how life changes are then affecting hormonal changes. So what is menopause? It's 12 months of no menses, of amenorrhea. The average age in this country is 51. In the OI community, it's the same number. And it comes from the Greek, whatever, you know, cessation of menses, ovarian function stops, and it's the permanent end of fertility. But what are the physical changes of menopause? And it really is weight gain, which is not great for bones, decreased bone mineral density. And I want people to remember that you lose bone mass, you start to lose bone mass 5 years before your menses stop. And if that's one thing that we could get into the heads of our women with OI is don't come and talk to us when you haven't had a period for 6 months, right? You're 53, you've lost bone mass for at least 5 years. So again, just trying to get people in, establish baseline DEXA scores, follow people before their menses stop. And, you know, obviously these are universal precautions that we would tell any woman: vitamin D, calcium, weight-bearing exercise, strategies to prevent fall. Tobacco and alcohol are not great for bone. And alcohol has been, chronic alcohol use has been linked to breast cancer. And so again, I think having these kind of discussions globally, when you see your patients at the right age, talk to your, people need to talk to the provider about bone health. And this is where I think that there's huge debate, and I'm going to open this up to, I'd love to hear from all of you. Gynecologists truly believe that hormone replacement therapy in the patients who would like to be treated is beneficial. It is not, estrogen is not a bone building agent. It's a bone stabilizing agent. So it's not going to build bone, but it'll stabilize what is there through inhibition of the osteoclast. It has other benefits in terms of cardiovascular risk. and it has negatives. By and large, the internal medicine community as a group would like people to be on hormone replacement therapy for 5 years and then pull it away. And it's just this ongoing debate, because the issues then are, if you're on hormonal replacement therapy, it does increase your incidence of breast cancer, endometrial cancer. It does not, there's no data suggesting that it benefits Alzheimer's disease or senile dementia. But women who are on it will tell you that their sexual health is better, they feel better, they don't have hot flashes, they don't have sleep interruptions, so many things. And so we as providers have to help our patients, from my view, understand the pros and the cons, and particularly for OI clinics, what is the benefit to bone and how are you going to manage that? It does not work as well as bone building agents that we have historically all used. And so with that,
Great.
I'm open to any questions or discussion.
Thank you very much.
I had a question about your scoliosis comment, because you'd said that in the third trimester that you monitor it. Do you monitor with X-ray? I'm confused. And then
No, I'm not an orthopedic surgeon, but we actually just send them to our pediatric. Our pediatric orthopedic surgeons, like so many of you see adults, and we just have them monitored by a
Just clinically, okay.
Yeah,
Yeah,
just
I
make
was-
sure it's worse,
well,
not
and-
worsening.
And also, or I want to know if you have any feedback. I mean, we've always tried to limit spinal fusions, 50 degrees or more or less, but should we be doing things a little differently in women in anticipation of childbearing? Based on what you've seen?
I don't know, I'm gonna
Like,
ask
are they
the
progressively
surgeons. I
worse?
mean, look, Peter's saying no, right?
Yeah.
Yeah.
Yeah, mild curves, no. But very, very large curves in a young woman, I think,
Yeah, obviously, we want to avoid those
right.
if we can, but I think your data was, you said over 100 degrees or something.
120 is where they've shown bad pregnancy outcomes. This
Yes.
is really historic data. I mean, we don't see
So-
people anymore like that, right? So, when people say there's a kyphoscoliosis, I say, well, the data is 120 degrees will affect pulmonary function, which will affect pregnancy. So, yeah.
Yeah, we've gotten more aggressive on spine fusions in the more severe patients earlier, but not very severe. But 120, forget that. Nobody should ever get to 120.
Right, but that's historic data. The presence of rods does not contraindicate regional anesthesia. These are the questions that I guess asked all the time. I just have them meet patients pregnant, just meet with the anesthesiologist.
So I have a
Just
question.
to our folks who are,
Sorry, go
excuse me, just one thing. To our folks who are online, I'm monitoring the chat, and we hope you'll feel free to participate, and we'll be glad to read off your questions if you have them.
So my question is around birth control. Last time I went to the Endocrine Society, there were some statements regarding progesterone-only pills, lowering estrogen, and that might be bad for the bone. But when I researched the literature, it was very mixed about that. So I just wanted to know your opinion on either the progesterone-only injections or pills, and if you recommend that or not, or really don't think it impacts the bone.
I think that that's a great question. And the answer is, I don't know. I think overall, I'll defer to endocrinologists, but overall, long-term progesterone, unopposed progesterone use, long-term, not a good thing for bone. And where I see it is not in the OI community, is the geneticists. We also see young girls, women who are mentally really very disabled and can't handle having menses. And so we give them Depo-Provera shots to try to help them and their families. And we know that chronic years of this Depo-Provera is actually very negative to bone. So I wouldn't advocate progestin only unless there was a good reason. Okay, thank you for your attention.
Deb, I'm going to push you because you alluded to the controversy, but I want you to tell us what you are telling women when they do come to you at menopause and ask for help. What precisely are you telling them? Controversial. This is not.
This is really controversial. It's really controversial. And yesterday we had a long discussion about the role of testosterone in men and health. So I hopefully don't see people when their menses completely stop. But what I do recommend is I do a really detailed family history to make sure that there is no strong incidence of breast cancer. If there is, then I actually do, even if it's a single relative, I'll do testing for other for genetic causes of breast cancer. You know, obviously we know about BRCA1 and BRCA2. There's other ones like Paul B and check. There's a whole panel, right, that are minor contributors. If there's no family history of breast cancer, then I have the discussion. If there is a family history of breast cancer and the panel comes back negative, then I go to the same discussion, which is that there's benefits to bone. I'm a rational human being. I follow their DEXAs. If they continue to lose bone on hormone replacement alone, we have to add another agent or it's not the answer. People like hormone replacement for other reasons besides bone, right? And so I will continue it. It turns out, and this is where the controversy is among gynecologists and other individuals. If you take hormone replacement and you get either endometrial cancer or breast cancer, you actually get estrogen positive tumors and they're easier to treat. So you get a less aggressive form. If you look at the tumors that, breast cancer that occurs with hormone replacement, it turns out that nobody wants to get cancer. So I'm not, this is the controversy, but that it is, estrogen positive tumors are much easier to treat. And so I'm not advertising it, but as long as the patient knows the lifetime risk, I think it's worth a discussion. Look, I mean, you're between a rock and a hard place, right? 1 out of 9 women or 1 out of 8 women in this country is going to get breast cancer. It's going to be the same in our OI community. And how do you manage that in terms of the benefits? And that really remains the debate.
You made one other comment I want to push you on. So am I right that there has been or are you saying that there's been, I have to get closer to you. All right. Are you saying that there has been a return to hormone replacement therapy for 5 years?
Oh yeah, the gynecologists have been, the women's health study. I think the women's health study where the recommendation came, oh my God, this is horrible. We're seeing breast cancer and we're seeing increased cardiovascular events, which actually influenced everyone to say no more than 5 years. If you look at the study design of that study, they did things in that study we would never do, which is they put women on hormone replacement who were 10 years post-menopause and in their 60s, and then put them on hormone replacement and then said, oops, we got problems. So I'm not saying the study is bad, but if you look, there's a lot of controversy. And so I still think that at least for 5 years or for the period of time that is reasonable with, ongoing monitoring and understanding, I think is really what's important.
As a pediatric orthopedist, I don't have that many adult women patients, but I do have some. And what's interesting to me is they have been told absolutely no hormones. So you're really speaking to a change that has not been universally accepted.
No, it's not.
Yeah.
It's not. It's really it's an ongoing daily. It's daily. It's a big debate every single day on what to do.
But I think that my conclusion from what you've said is for our adult women, they would, as long as there's no reason not to. We want to be sure that they all are on hormones for a minimum of 5 years.
No, I'm not making that recommendation. I'm making a recommendation that people who start to have irregular menses and start to have symptoms actually address their bone mass and meet with a gynecologist, and perhaps have a discussion between the gynecologist, their internist, their geneticist, whoever's running these clinics, to decide what is the best, because it's more, I mean, it's sexual. I think the next speaker is going to talk about sexual function. And, you know, we know that women without 20 years of no hormones are showing up with recurrent UTIs. You know, there's other reasons to have estrogen around. And for me, I mean, this chronic UTI issue that we see in people in their 70s and 80s is really hard to treat because the vaginal walls are really thin, their urethra tissues are really thin. And if you talk to the GYN urologist, this has now become, you know, a real problem for them. Erin.
Wait. You can't be heard.
Sorry. I just wanted to comment as seeing adults that we have women who are on the other side of that also, who did hormone replacement therapy, have side effects, have to go off. And then they're asking, so what about my bones now? I'm in my upper 60s and 70s. I have no data. That's just an anecdotal question and concern from some of our patients.
Yeah, I mean, I think Dr. Orwell spoke to it. I mean, we then just go to bone building agents, you know, whether it's oral agents, it's anti-sclerostin, it's teriparatide. I mean, you go back to your armament of what you think you can do. Thank you.
And we clearly need more research on that as well. That's for sure. So not the usual OI clinic or not the usual OI topics, but here we keep going. And now it's my great pleasure to introduce Dr. Michelle Fynan, who's going to talk to us about sexual health in our patients. If you click that to your address.
Belt. Maybe I'll rest it.
Okay.
Okay. Oh, I have a belt. Can you see me on the thing? Because I'm going to stand to the side. Yep. Okay, so first and foremost, thank you all so much for being here as a member of the OI community. You all mean so much to me. I don't even think you can understand. So I just so appreciate you. I appreciate everyone at the OI Foundation making this happen. Dr. Tosi, I'm very happy to be here as not only a woman with OI, but a mom to 2 little ones with OI. I heard a lot of pediatric doctors being mentioned here. So I'm very thrilled. And I know that one goal of this meeting was to talk about opportunities for improvement when it comes to the care being offered to people with OI. And that's why we are talking about sexual health today. A little bit about me. I have my PhD in clinical sexology. I've been a licensed mental health counselor for a little over a decade. And as I mentioned, I have OI. I was the only person in my family with OI until both of my daughters were born. And so I say that to say that I'll be wearing a few hats today as I share everything, the clinician, the mom, and then just person with OI as well. So my own experience will be woven throughout, as well as what research has shown me too. So here is where we will be going. My main goal is to have us understand why talking about sexual health is so very important. And why acknowledging the sexual health of your patients will really lead to an overall improved quality of life. Next, I want to support everyone in feeling a little bit more comfortable in talking about sexual health. I know that just discussing disability can be an uncomfortable topic. Sex can be an uncomfortable topic. So then when we merge the two, sometimes we're not talking about them. So we want to increase the level of clinician and patient comfort in discussing sex and sexual health concerns. And then how do we do that? We would want to look at what the needs are that people with OI are reporting. So we'll start with our why acknowledging sexual health is so important and why it will improve quality of life. So acknowledging sexual health is supporting the fact that people with disabilities are sexual beings. And this is something that is typically not viewed in society. And being the eternal optimist that I am, I see that shifting. There is dialogue happening, but we still have a way to go. So like I said, people are just uncomfortable with these topics. And then when we merge the two, there is, just this lack of communication about it. So our goal then is to expand our zone of tolerance, if you will, with these topics, so that we can be more comfortable and then in turn be more comfortable create that space for our patients. And I recognized even while making this presentation that the topic in and of itself, just seeing it there, being like, is she saying that we need to start talking about sex with our patients on top of everything else that we're already doing? So I realized that in and of itself could be uncomfortable. And then, of course, with perfect timing, just this week, I had to have my very own sex talks with my kids because down in Florida, it is springtime and the animals have no shame right now. So those conversations are happening. And I think it happened in perfect timing because I was like, this is not the most comfortable conversation. And I'm a sex therapist, right? So I just want to acknowledge that this might be the case. And for you as you're sitting here, and then also it might be the case where you're like, well, I'm completely comfortable talking about this, but it really is that timing of, I have so much to cover. How am I going to also work this in? So I really just want to reassure you that in no way is the saying you're an OI specialist now also have the sex talk. That would be weird, but what we do want to have is a conversation about shifting into this space of just acknowledging people with disabilities and their sexual health, acknowledging them as a sexual being and in a whole human type of way. So, and that's the type of shifts that I want to talk about, because research tells me, and self-report from many of my clients and even just friends with OI tells me that when a person with a disability is trying to have that conversation with someone, especially if they're in a position of authority or power or respect, and that person is exhibiting a level of uncomfortability talking about it, oftentimes that is internalized. So it's internalized as, oh, this is not something that I should be talking about. Maybe as someone with a disability, I'm not going to be having sex. Maybe that's something that I need to be aware of. So it really communicates on some level that there's not a seat at the table for you with this discussion. So that's something that we really want to work on shifting. Again, in society, people with disabilities are viewed as this inspiration, maybe often heroic, and or maybe even needing more, maybe victims, maybe things in that way where they're not being viewed as sexual beings. And how people view themselves affects their self-esteem and their sexual self-esteem. So what is the difference there? Self-esteem is just your confidence in who you are, whereas sexual self-esteem is your confidence in experiencing yourself as a sexual being. And many people with disabilities have internalized, dominant, ableist, heteronormative views of strength, of beauty, of sex, of sexuality. So these negative beliefs impact self-esteem and how we are viewing ourselves, and is correlated with psychological distress a lot of times. So, and as humans, we just play these tapes in our head that we have learned through society, friends, family, ourselves, and that impacts our sexual self-esteem. Literature addressing self-esteem among men and women with disabilities strongly suggests that it's not the disability per se that is influencing self-esteem, but rather the contextual, social, psychological, physical, emotional experience of it. And it goes on to say that negative attitudes, lack of opportunities, and social isolation are really the most prominent barriers here that have a very significant impact on life satisfaction as well. So there's a strong correlation between life satisfaction as well as sexual satisfaction. And that's our big why, right? We want to be improving overall life satisfaction. And we also know that when things are uncomfortable, right, and negative attitudes are present, then that's also where lack of resources, lack of education, this is where myths can then pop up, right, and misconceptions about sexual health. These are myths that I have heard, that I can't have sex because I have OI, that I can't get pregnant because I have OI. And then there's also that, well, I have a disability, so I've already like checked the box on like bad things or, you know, health related things, which unfortunately is not true. So with that said, when we're not talking with patients about this very big part of themselves, we're denying that part of them. If on the other hand, we are creating space for sexual health questions to come up, we're acknowledging the whole person. We're saying, of course, you have a seat at this table. Of course, this is something that applies to you. And that in and of itself can be very powerful in combating the negative scripts that are often going around. So what do we need to do? We need to increase our zone of tolerance, right? Which will in turn increase our patients' level of comfort in talking about these things with us. So it's almost like, well, you may open up the floodgates here. So if this is your mission, should you choose to accept it? But I'd like to invite you all to do a little bit of self-reflection now for yourself. So on a scale of 1 to 10, 1 being I am completely uncomfortable talking about sex with my patients, and 10 being I am so comfortable I'm going to share lots of tips during our Q&A part. Where do you think you fall? And you can just kind of keep that yourself. And then I want you to also think, what would that next number up look like? Like if I'm a 5 right now, what would a 6 look like? What would be different? And then hopefully we can have that shift even happen by the end here, just by talking about it, feeling a little bit more armed with what to say. So now we've assessed our comfort level. Let's also see in what ways have you maybe already been providing this space for your patients and acknowledging them already. And we can ask ourselves these questions. Am I providing the same information to patients who don't have OI? Are we having those same conversations? Am I assuming my patient's sexual orientation? Am I assuming gender identity? Am I providing accessible sexual health resources? Am I mentioning sexual health at all? So all of these questions, it's not only an opportunity to kind of celebrate what's going well, but also we're seeing, oh, that's something that I could just add in here. And we're also scanning for potential bias. So if we find, oh, I'm not saying certain things with some patients that I am with others, then that's a great opportunity to check ourselves. So the good news is you don't have to be a sexpert in order to be having these conversations. Many individuals with and without disabilities have questions about sexual activity and that they want to be discussing with their doctor. And often these questions are not being brought up. According to a study that was exploring the barriers and solutions in healthcare for individuals with physical disabilities, this population is actually a lot more likely to bring up these questions with their doctors. So being prepared, so they're more likely than able-bodied patients to bring up these questions. So being prepared can increase our zone of tolerance here and help us feel more comfortable. And a study conducted that examined the level of comfort among nursing students showed that there were a lot of beliefs about why it shouldn't be brought up. So some nursing students were reporting that they felt like it was inappropriate to discuss unless the patient brought it up, and that it shouldn't be talked about as part of the evaluation. But what was then shown was the opposite is actually true, that these are things that need to be discussed, and that people with chronic medical conditions are typically being left out of the conversation when it comes to sex education as well. So they're not having the discussion at home. They're not having the discussion anywhere. So how do we make sure that that information is getting to them? How do we create this safe space, really? So if sex questions come up, you might also be the first person to be having this conversation. So no pressure, but also knowing that it doesn't have to be something where you know all of the answers either. At this point, I'm really feeling into this idea of not immediately jumping to a referral. So a common report for people with OI and other rare diseases, I do a lot of work with the rare disease community. There is this feeling of being too much and having a lot of, well, I don't know how to help, so I'm going to send you this way. When in reality, a lot of the conversation could really just be a collaborative discussion. It could be mostly just listening, and it really would, a lot of the same things would apply to the person that is asking these questions. So there's this common theme. And then of course, if it's out of your scope and they're asking very specific questions, obviously we're going to refer, but just making sure that instead we're also really having collaborative dialogue here. You could ask your patients, how does your disability impact your sexual health, if it does at all? Do you have any sexual health concerns? Are you sexually active? What are your pronouns? And these are even things that could just be put into your paperwork too, just so that it's supporting the idea that this person is a sexual being. We're bringing this part of them up in conversation. So how do we do this best? And one way to do that is to anticipate the needs of our patients. And we do that by having conversations. And I'm happy to share some reports here about what people with OI have shared with me as far as what they are needing from their physicians when it comes to talking about sexual health. So I'll go ahead and read this so that you don't have to squint if you forgot your glasses. So there's a lot of stigma around people with disabilities and sexual health. And I think openness, especially in a safe healthcare space, is important to break down those stigmas. I grew up in a household that didn't talk about sex, and I felt very unprepared and fearful because of it. I'm having issues with intimacy with my boyfriend, and I'm experiencing pain. I've tried to find help, but doctors in my town barely want to go near me. I do think it's important for bone doctors to at least talk to patients about how injuries and mobility can affect one's sex life. For example, as a woman in my 20s who is sexually active and recovering from a hip injury, I have had to adapt and figure out what sex is like with my. There's also a bit of anxiety of how my sex life will be long term, given how complex my injury recovery has been. So those were just some mentionings of people who were reaching out to me to share. There's also common concerns that I hear across the board in working with people with disabilities and then also people with OI. So there is fatigue, which is associated obviously with different types of disabilities. So things that can be shared with your patients as far as their needs go, if they are reporting fatigue and that it's affecting their sexual health. Just recognizing how it can lead to a decrease in sexual desire. When we're dealing with fatigue, we want to look at what medications or when are you taking your medications and how do we work around that? How do we work around different times when maybe you have more energy? Breathing and relaxation techniques can really help with fatigue, but also pain management. And because pain is also a big fatigue culprit. We've also got bone fragility. So that concern could be minimized by utilizing different positions that don't put all of the weight of the partner on top of the affected person. So side lying positions are always recommended. And that could be even just for pain. Again, even if fracture isn't present at the time or injury isn't present at the time. Dr. Krakow was mentioning the scoliosis and how that could also affect sexual positioning as well. I've had people report that their doctor actually took that into consideration prior to doing their surgery. So where they were as far down as they were going on the spine with the rotting, that was taken into consideration, even though surgery was done at a young age for this patient. So we're looking ahead and we're considering that this person in front of me, even though they might be a minor, even though I'm a pediatric doctor, they are at one point going to be, they are a sexual being. They may at one point want to be having intimate relationships that this surgery could then affect. Limited independent mobility. So just talking about maybe requesting assistance. Additionally, letting people know that there's adaptive sex tools that can be used to assist not only with pleasure, but also sexual positioning. Limited range of motion, that is another one that comes into play, especially for when deformity is present or if hip injury, as was mentioned in the previous slide. And so we're looking at what positions could reduce the possibility of having, further problems when it comes. So not having the hips be straining during sexual activity and looking at different positioning for that as well. So again, these are just the common concerns that we have heard. The final thoughts, we don't have to know everything. We don't have to know all of these tips. We can refer to people like myself. We can refer to other clinicians as far as this goes. We don't have to know it all. But if we do start to consider how our paperwork and how our conversations can start to be shifted in order to include this type of conversation and make space for this conversation, then we're moving in the right direction. Again, you don't have to be perfect. And as I've found with others in the rare disease community, we are typically more accepting of not being perfect. Some of us have worked with doctors who never even heard of OI before they met us. So being able to just navigate these concerns together can be extremely helpful. So this is where we went. We were looking at improving quality of life by acknowledging sexual health, increasing our level of comfort when we're talking about sex and sexual health, and then also talking about the needs of people with OI when it comes to this topic. So we've gone over everything. I also want to invite you to remember back to your scaling question of where you were at and think about what that next number is. Hopefully this has contributed to getting you to that next level up. So hopefully we've leveled up today, and I'd love to hear any questions that anyone might have.
Hi, Michelle. How are you? Hi. Do you have resources? Do you have, websites, pamphlets, things that we could provide for our patients that do have questions? If we don't have all the answers, without just referring them, have you put together, or the community, do you know of reliable, good information that we can?
Thank you so much for asking. So I'm so glad that Dr. Tosi had everyone introduce themselves, because I kept hearing pediatric, 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 and there are so many different developmentally appropriate conversations that can be happening all along the way. And I was like making notes. And so I will say that that is something that I will be having available for everyone. I'm happy to throw all the resources together so that you are going in with something to give, as well as just the knowledge that you already have. So thank you for bringing that up, for sure.
I think one of the big issues for our patients, frankly, is, the old "don't get pregnant."
Mhm.
Harsh, but honest. And yet the kids want to be like everybody else. Any thoughts on just addressing the anxious teenager?
Yes, I talk to many anxious teenagers and adults, really. And what I'm finding is that I'm having those conversations with adults that typically you would find in anxious teenagers in the able-bodied community. So really just acknowledging that, and this is interesting too, because sometimes it's from the parents that you can't have sex, you can't get pregnant, you can't do this. And it's obviously from a fear-based perspective of, what if you have a child that now has OI? How are you going to take care of them if so really just encouraging to everyone going to these OI community events, when you're able to see, oh, this person has OI and they have a child and they're able to do it. I know that that was a big thing for myself, being able to see someone who looked like me, who had a family and was able to do everything the way that they were. So I think it really is peer conversation, encouraging that as well, and sharing with them the realities of, you might have a child with OI. Is that something you're ready for? Or and talking about just being open with the idea that you can still have sex and still have sex for pleasure without it being when you're family planning.
Yeah. Hi,
Yes.
Dr. Fynan. We have a question from the audience here. It's asking, where can we direct patients to find adaptive sex tools? We have older patients who are asking about adaptations.
Oh yeah, there are so many. I mean, go to my Instagram. That's where you need to go. There are so many. I think that would be a really great resource for me to compile as well. I'm going to have a lot of work after this. But yeah, if you even just are Googling it, but of course you want to find a reliable source. Yeah, I'm going to have to make a wonderful, exhaustive list for everyone. For sure. Thank you.
We'll hold you to that.
Yeah.
Because it really is an issue. Dr. Cruz.
As a patient with OI, were you prepared to be a parent of a patient with OI?
Not at all.
Prepared to be a
I
parent?
thought that I was, but I was not prepared. And I think that has really lit the fire in me to be doing all of these things now, because sex was not a conversation that was had with me, which again did lead me to believe that it was because I guess I just can't. But that isn't usually where someone's head goes to if their parent doesn't have the sex talk with them. That's a very unique to like disability scenario. So now I'm trying to like relearn how to navigate these questions, because I'm, again, as a parent, I'm having to have these conversations as well. But I don't know that I was prepared, also because of having mild OI too. My kids are actually a lot more mild than I was. So it's hard to see them be able to do the things that I couldn't at the time. I was in a wheelchair for about a third of my life. I wasn't using a walker for the other third, and now I'm not using anything, but they have been very mobile. So it's been a big switch for me to like let them do things where I'm thinking they're gonna get hurt. So it's been a wild ride.
Thank you so. Thank you so very much.
Thank you, everyone.
Just a great start. And of course, I'm going to give you homework.
Oh,
That's for sure. All righty. Now it gives me great pleasure to introduce our third speaker of the morning. And poor Jeanne, I told her she could not talk about long bone fractures, but had to talk about some of those hidden things that we really worry about. And so she stepped up to the task, good woman that she is. And if you have patients with challenges, she'll be here for you to ask those questions. We're just bringing up her slides.
Great. Well, thanks, Dr. Tosi, and thanks to the OI Foundation for really this tremendous gathering. And hello to our virtual crowd as well. This will
It'd be rude to get some coffee.
this will get the job done.
Yes.
That's because you already know how to solve all these problems. Great. Well, thanks again very much. This is an exciting meeting here. As Dr. Tosi mentioned, she asked me to talk about challenges in our orthopedic care beyond the long bones. This is a picture from some recent training I did for a race up in New York. And this is a pretty steep hill. That's not at the top of the hill. That's clearly my friend who's way better at running hills than I am. And I think we have to look at a lot of these challenges like this. We have to look to all of our colleagues in this room to put our brains together and really work with each other in the OI community. So that'll be a theme during this talk. And I think this talk will really probably instigate more questions than answering them, but that's exciting with this group here. So the topics we decided on are protrusio, basilar invagination, as well as care models and young adult decision-making. So acetabular protrusio is certainly not a recent described phenomenon in the setting of OI. This review from 1971 clearly described acetabular protrusio as one of the orthopedic manifestations of OI, and this very descriptive X-ray is shown here. So what exactly is acetabular protrusio? Well, there's a few different ways of measuring it. You can look at something called the center edge angle, which is shown here in red. And the larger that gets, the more deeply covered and seated the femoral head is. You can also look at ways of assessing migration of the femoral head medial, essentially into the pelvis. And there are different measurements. We won't dwell too much on the specific details here. Professor Glorieux, who's here with us today, and his team in Montreal really gave us the first initial series and look into acetabular protrusio in the setting of OI with our modern classification system, and very clearly showed that those with more severe OI tend to have more severe acetabular protrusio. And then our colleagues up at HSS have also shed quite a bit of light on this challenging condition. Dr. Raggio and her team here showed us the association with proximal femur fractures, as well as specifically femoral neck fractures, which can be challenging to treat. This is one of their patients, a 10-year-old girl with type 3 OI, who developed this femoral neck fracture in the setting of acetabular protrusio, and this shows how they fixed it. The HSS team has also given us a little glimpse into the progression over time, that acetabular protrusio is a dynamic process and it doesn't get better, it tends to worsen. In their series, vitamin D, bisphosphonates, and physical therapy tended to reduce the risk of developing acetabular protrusio, but the statistical significance was not quite there. This is one of our patients. This is a 15-year-old girl with severe OI against an age-matched 15-year-old young woman without OI. And you can see the dramatic difference between both the pelvic and acetabular morphology in these two pictures, really an envelopment of the femoral head into the pelvis. When we look at this 3D model, and we're using more and more of these to understand this phenomenon, we can see is this is not purely an acetabular deformity, meaning the ball and socket part of the hip. This is really a true pelvic deformity with collapsing inward of the entire pelvis. And our colleagues in Korea have, with this recent very large review, have really, in very exciting terms, brought this to light as well. They helped us build beyond that classic acetabular protrusio. They looked at almost 300 hips and almost 600 patients with a typical breakdown of the types of OI. One of their benefits is that they did include adult patients, so they had that progression. When they looked purely at the center edge angle being greater than 40, there were about 20% of patients had a deformed acetabulum. And again, there was a significant increase as OI severity increased. But what this paper really adds is when they looked at the 3D CT scans of a subset of these patients, they made 3 categories, not 2. A normal acetabulum, classic acetabular protrusio with an increased center edge angle, and then this phenomenon called PPAD, or pseudo protrusio acetabular deformity. And they described this in patients who didn't meet the classic definition, but they saw this abnormal acetabular morphology. I think this figure shows it well. They described the crumpled hemipelvis. The acetabular roof tends to rotate upwards and medially, and the hip center migrates well into the pelvis. Sometimes, interestingly, because of the tilt of the pelvis, the anterior part of the femoral head is undercovered, not overcovered. So this was, I think, especially as we look back in future years, this will be a landmark paper and already is. So what are the clinical implications of this? How does this affect our day-to-day practice? Well, GI problems have long been reported in the setting of severe OI, specifically constipation. And we know constipation is multifactorial. But this figure here, this is from 1995, this barium study very clearly shows a severe constriction at the site where the protrusio is the most apparent. This patient was suggested to have a diverting colostomy, but the paper mentions rather manage this with daily enemas. But a really exciting new publication from Dr. Wallace and her colleagues in Omaha report on 2 patients with, again, severe OI, severe pelvic deformity, and acetabular protrusio. And both patients had obstruction of the colon, refractory constipation, and underwent diverting colostomies with very, very good results in terms of health-related quality of life. In terms of the orthopedic clinical implications, the hip range of motion is certainly affected when the femoral head is socked so deeply into the pelvis. There can be associated hip pain. In ambulatory patients, the gait tends to be affected, and the femoral neck fractures associated with this are very challenging to treat and sometimes even to recognize. This is a 16-year-old patient of ours, had long-standing left groin pain that we hadn't really been able to sort out too well, and had a misstep from her camper and had this acute worsening of deep-seated groin pain. It's very subtle on the x-ray, but if we zoom in on the femoral neck, you can see a non-displaced femoral neck fracture. It would be easy to miss this if you glanced at this x-ray without knowing the exam and the clinical story. We tend to get CT scans for these patients to better look at the femoral neck, understand its anatomy, and plan our surgical fixation. And what's really interesting is you see this whitening area around the fracture. We call that sclerosis, and it indicates that there was probably a lot of stress on the bone here, and this was an impending fracture for a period of time. For the surgical fixation, we stabilized the femoral neck, and then also because of the rod being protruded, we revised the rod. Made the decision to put the rod in from what we call a retrograde approach through the knee, as opposed to moving the hip and stressing our femoral neck fixation. 3 months post-op, she had healed. These do tend to take longer to heal than some other fractures that we see. But unfortunately, 1 year later, no prodromal discomfort on the right side, leaned down to pet her dog and had this acute right groin pain. You can see this non-displaced femoral neck fracture a little bit more clearly. The CT scan, again, was very helpful for planning surgical fixation. And even without those prodromal symptoms, we see that sclerosis there. So this is the surgical fixation here and went on to heal. This is 4 months post-operatively returned to baseline function. This is an 8-year-old boy. You can see even at age 8, he has very severe acetabular protrusio. Showed up for an infusion one day and he said, you know, my right hip's really hurting me. It hurts when I walk. That doesn't seem to be getting better. So on this x-ray, we were worried for a femoral neck fracture here right near the growth plate. This was him walking in our suite, and you can see that right hip is clearly bothering him. The CAT scan did show a non-displaced femoral neck fracture in the setting of the protrusio and what we call a coxa-vara deformity with this abnormal proximal femur. The reconstruction for this entailed reorienting the femoral neck as well as revising the intramedullary rod. So we're not taking away that protrusio per se, but we are at least bringing the femoral neck away from that impingement site. But again, this is a challenging condition. This affects our planning and our execution of surgeries in the operating room as well. This is a 7-year-old boy with Bruch syndrome undergoing a left femur revision. You can see he has acetabular protrusio on this side, and because of his Bruch syndrome, he already has limited motion in this left hip. So again, instead of doing an antegrade realignment and intramedullary rodding, we did the telescopic realignment and intramedullary rodding from a retrograde approach through the knee. This is 4-year follow-up. He hasn't grown too much, but the rod is holding on and doing its job. Unfortunately, consistent with the natural history, the protrusio continues to progress. We find this particularly challenging in patients who have a spinal fusion that extends all the way down to the pelvis. That takes away another motion segment, really leaving the only motion segment between the pelvis and the legs, this hip with a very deep seated femoral head, and limited motion because of that protrusio. This 21-year-old young man presented to us with severe lateral left hip pain. He was having a very hard time transferring himself because of limited motion in his pelvis. And through a physical exam and workup and using this 3D CT scan, we really identified the source of pain as his proximal femur abutting into the pelvis. And you can see there's a prominent rod there as well. So the surgery in this instance, after significant discussion and planning and, like I said, diagnostic workup, involved resection of a part of the left greater trochanter, and we also reinserted the nail to take away that prominence. Unfortunately, he is clinically doing well, but again, it doesn't treat the protrusio itself. It comes at it from another way. And unilateral protrusio is something we really don't understand all that well. How do we explain this 16-year-old young woman here who has really what looks to be a normal hip on the right side and a pronounced acetabular protrusio on the left side? And same for this 19-year-old young man. I think it's not a coincidence that they both have it on the side that's undergone, as you can see, a lot of reconstructive procedures, but this is fascinating and we don't quite have the answers. So what do we know and what can we do? Well, number one, know about it and be aware of it. I think that's the first step. Who develops it and what is the natural history? Well, it's more common in those with severe OI. It does worsen over time and it has clinical implications. Are there ways to prevent the development? Well, like we said, optimizing vitamin D, bisphosphonates, weight management, those likely play a role, but we don't have great data. Is there a role of early weight bearing? We really don't know that answer now. And, lastly, are there ways to manage it and treat it? Well, yes, like we said, avoiding forced hip motion, considering femoral neck fractures in the differential diagnosis, managing constipation, it affects our surgical considerations, but ways to treat it, not per se. So that's where we need this crowd to all put our brains together. Before we leave this topic of protrusio, something our site is interested in, and this is just a little series from our patient population, is the same phenomenon in the shoulder. You can see this is an unaffected 17-year-old and then an affected 17-year-old with severe OI. And that humeral head, very much like the femoral head, we feel it really becomes enveloped by the shoulder girdle bones, and very similar clinical implications affecting range of motion and sometimes an antegrade approach to the humeral head. And this is important for a population that depends on upper extremities for day-to-day functioning as well as recreational activities. So moving on to our next topic, basilar invagination. It seems like a big jump, but when we really think about it, it is actually a protrusio of the upper cervical spine into the brain. So similar phenomenon. So basilar invagination, or BI, is exactly that. This image on the left is a patient without BI with a normal relationship of the upper cervical spine to the brainstem. On the right, what has happened is the brain has really settled onto that upper cervical spine, or you can think of it as the upper cervical spine protruding into the brain. This is one of the craniocervical junction abnormalities we see in our OI population. There's two others. Basilar impression is essentially a more mild form of BI, and platybasia is flattening of the skull base. But one of these three is present in almost 40% of OI patients. So this is an important clinical consideration. But not all patients who have one or all of these three findings are symptomatic. So what are the symptoms? Well, unfortunately, they're highly variable. Headache, hydrocephalus, and various forms of lower cranial nerve dysfunction, such as swallowing issues, ataxia, autonomic dysfunction, and sometimes we'll see hyperreflexia. But again, these are variable and can be very vague symptoms, which is why our guard has to be up for this condition. There are lines that can be drawn on an X-ray. We won't dwell on the details of those, but sometimes the landmarks are very hard to find on an X-ray. So we do have a low threshold to do an MRI when we're clinically concerned. And what is the management? If patients are asymptomatic, they do need to be closely followed. If there is associated hydrocephalus and patients are symptomatic, a shunt can help decompress the hydrocephalus. In terms of surgical treatment, our institution's preference is to reduce the BI with a form of halogravity traction and then come from a posterior approach. And our spine surgeon works with our neurosurgeon to do this, to fuse the upper cervical spine to the skull base. There is described in the literature an anterior approach, which carries a significant comorbidity as far as that surgery is concerned. So I think the best way to talk about BI and some of the implications is to tell a story. So 28-year-old young man with severe OI, we met in unfortunate circumstances, manager at work before this happened, living independently, wheelchair user, didn't really have infusions or access to multidisciplinary OI care growing up and into his young adult years. He was airlifted into our hospital, and prior to his current hospitalization, digging a little bit deeper with him and his parents, they did notice his head size had increased a little bit between high school and college. Maybe his eyes had been bulging out. Had hydrocephalus 6 years ago, was airlifted to a hospital, treated with a shunt. And then on probing into some other symptoms, perhaps there had been very subtle neurologic deterioration over the past few years, slightly slurred speech, wandering eyes, but none of these kept him from living independently and doing his job. And then prior to, that was the already compromised usual state of health. And then he was hospitalized with the flu, had a very complicated hospital stay, including multiple intubations. And then was weak and transferred to rehab because he was felt to be due to deconditioning. But the weakness was fluctuating. He developed clonus, and an MRI was done that showed BI, and then transport was activated. So he arrived with a trach, able to blink, very minimal control of upper and lower extremities. And this MRI is probably one of the most dramatic examples of BI that we've seen. Your upper cervical spine should not be in the middle of your brain up there. So our team attempted halo traction to decompress this fusion from a posterior approach, but the gains were really minimal, and he actually passed away a few months later. So beware of BI. Know it exists. OI care is more than fracture care. Get an MRI if there's a doubt, make a referral, and be careful when intubating. So it's a sad story, but by sharing it, we can, help our community recognize this condition better. So we'll move on to our last topic here of advancing care over time and delving into the care of young adults. So this is a 27-year-old who's followed in our program, and you can see here has had a spine fusion, lower extremities without rods. She's a delightful young woman, but unfortunately highly not independent in day-to-day care. Needs assistance for all transfers, and other than the spine fusion, had somewhat limited access to care growing up. And how can we contrast that 20 years later to a 2-year-old who we follow now? So this 2-year-old, you can see here, has progressive femoral deformity, recurrent fractures. We're keeping an eye on spine alignment. Underwent realignment and rotting of both femurs and subsequently both tibias. And much to our delight, showed us just a couple of weeks ago that she's now going to walk into all of her infusions. So how do we advance care and develop this multidisciplinary model? Similarly, when we look at the generational gaps, how can we ensure that the young girl in this photo has access to a full multidisciplinary team and comprehensive care that's improved as compared to prior generations? So multidisciplinary care is absolutely critical, but not only that, a team that communicates. Bisphosphonates, as Dr. Tosi mentioned in the introduction today, have been tremendous, and also the new drugs on the horizon. Well-timed rotting, skull-based monitoring, as we've discussed, and access to spine care. We heard a lot about pulmonary care yesterday, and we will today, which is really exciting. An emphasis on activity, and then patient-reported outcomes that should be the center of care. And in terms of caring for young adults, as we talk about that transitional zone, it's somewhat different than caring for the younger child who I just showed with deformity undergoing rotting. The decisions are tougher and really need to be a joint discussion. This is a 19-year-old who presented with lateral right hip pain, and she said it's from the rod. And, we did a workup and imaging and x-rays with a little marker on the site. We did a diagnostic injection. We checked the femoral neck to make sure there wasn't a fracture. And sure enough, seemed to be the rod. So in the operating room, we did a revision rodding, took away that prominent part of the rod. But there's details at every step of this case to not more surgery than we need to do, because it will increase our complication rate. There's a known higher rate of non-unions in young adults. She'll be out of work, she'll be out of school. So these decisions are really critical. And I think something that, we need to develop moving forward. And lastly, in terms of transition of care, this is a 30-year-old patient who had been cared for and was lost to follow-up for time. OI kind of took the back burner, wasn't really taking supplements, but was out, working in the community, married, and came in with this right distal femur fracture. And this is a really challenging fracture. We were able to put her back together and get it to heal. In terms of surgical considerations, this is a 4-millimeter rod. They don't exist at many adult hospitals, and certainly a challenging surgery. But in the workup, we checked a vitamin D level. It came back as undetectable, and there were other things that had been neglected, cardiopulmonary aspects of transitioning to adult care. So we can do better than this. And this is our challenge. So what does that mean? Knowledge of prior care, surgeries, implants, not letting vitamin D dip to an undetectable level, educating patients and families about OI adult health concerns, access to a medical home, like Dr. Bober mentioned yesterday up on the panel here. So as Dr. Tosi will remind us, signing up for the registry helps this process. Engaging in Dr. Tosi's PCORI project focused on transition of care, that will help us do a better job. So thanks so much to our team at DuPont, and thanks to Dr. Tosi and our mentors here who we were able to reconnect with in person. Appreciate your time and welcome any questions.
Are we on? Yes. Great. Questions in the room? Pam?
Dr. Franzone, we actually have a question from the
Great.
audience first. I apologize.
Yep.
Dr. Krishnan, if you are still on, if you'd like to unmute yourself, we will hear you. Dr. Krishnan, if you are still here, we'd love to hear your question directly. But he was asking about, should this be referred to a neurosurgeon and an orthopedic surgeon for talking about the BI?
Yeah, I think that's a great question. And that does, there's variability at different hospitals of who is trained to address these issues and who feels comfortable. But yeah, there certainly are typically neurosurgical components to surgical treatment of basilar invagination because of the decompression. And then, again, it varies by center. At our center, the orthopedic folks are the ones who are more comfortable with the fixation that you saw, that fusion of the skull base to the upper cervical spine. But again, I think a frank discussion of folks training and awareness, and there is some variability, but.
Thank you.
Oh, sure. Pam had a question.
Thank you so much for that talk. It's actually a really overlooked area, I feel like oftentimes, especially by non-ortho providers. So we often focus on fractures and forget about these other aspects. I did want to ask for basilar invagination. Should we typically be doing imaging routinely or just base it on a physical exam? I feel like just go by physical exam, we've gone past the point. But oftentimes we only do scoliosis films when we do routine imaging. So that was my first question. Second question or comment is protrusio has become a very prominent topic in the adult community and actually becomes source of debilitation for many, non-ambulatory and ambulatory. And is there research in this area? What can we do? Myself included, I've had protrusio of both locations, and it's a source of chronic pain and only source of chronic pain, requiring potential prosthesis. There's talk of, and I have well-known OI community member friends who've needed replacements or discussion of replacement, and it's a fearful topic. And what can we do for the adults who've progressed to that point?
Yeah, thank you. Those are two great questions. We do typically do and recommend a screening lateral radiograph that shows the head neck junction sometime before school age. And, as you mentioned, we do yearly spine x-rays, and at the very top of that, typically you can see if there is progression there. But I think you hit the nail on the head that the physical exam and the history are absolutely critical. And like I said, the history can be so vague. We had, have had a parent show up in clinic and say, something's not right. It's like the light bulb went off. And that's, that sort of, instigated our concerns. And the physical exam, like you said, those neurologic changes. But once you are to that point, having that low threshold to do the MRI, it is important because of the limitations of x-rays. And the protrusio question is a well-timed one. And again, like I said, it's a challenging area. I would love to be able to say, once we have severe protrusio, we have, a surgical option to fix it. We're not there. I think we're learning more about it. We're, the 3D models are really helpful. The arthroplasty question you mentioned is fascinating because, it is challenging to do a total hip arthroplasty in the setting of protrusio because, getting that femoral head out and the implant sizes are also a consideration, perhaps needing a custom implant. So those are two great questions, and that's why we need to keep working. I saw Dr. Cruz has his hand up.
Yeah, it's more of an editorial comment. I'm hearing over and over asking questions that I think Laura, since it's a town hall, it's time for the paradigm shift. We're here because we have OI teams and we want to develop OI teams getting the best care. But, you know, for the questioner and all of us ask the question, should I refer to an orthopedist or a neurosurgeon? That's a short-sighted question. The ideal should be, who can take care of this patient? What team can take care of this patient? Mike Bober talked about a medical home. We have to reframe how we ask the question. When I refer this patient, is my referral have the adequate therapy, have the adequate team? It's a team effort. Taking care of these patients is not a neurosurgical problem, it's not an orthopedic problem, it's a team problem. And we have to change that, and that's why we're all here. So just an editorial for thought.
I couldn't agree with you more, because many of us have OI clinics, but it's not clear that we would always want particularly basilar invagination taken care of in our own clinics, because it is so specialized and so very, very difficult. But I think the reason that I asked Jeanne even to give this talk wasn't even the surgical management, it's that we tend to push this aside. And what I wanted to emphasize is the importance of checking for it. You know, in the old, you see what you look for, you find what you know concept is truly important here. And I don't know about your radiologist and your x-ray techs, but even when I get my annual x-rays, I get a separate lateral spine, separate thoracic spine, because otherwise the x-ray is so lousy. I can't tell if I've had more vertebral compression fractures. And so that I also need a separate neck film. And it's a lot of irradiation. And are you doing it every year? I mean, sort of what do you think about monitoring it? The OI Foundation traditionally has not set clinical guidelines, and we're going to actually talk about that on a different topic in the next session. But this is a life-threatening issue. And where do you think we are in terms of what we know about at least monitoring for this problem?
Yeah, I think like you made the great point that, you know, it's one thing to not know what we see, but it's scarier to not know what sees us that we haven't seen. So like you said, I think being aware of these conditions is probably the most important step. And yeah, you know, as far as monitoring, every facility will be set up a little bit different for the spine films. We do check them every year. Yeah, on one view have a lateral from, you know, essentially the head neck junction down, but it is always a balance, like you said, of that radiation and monitoring.
Yeah, and that's where my question was leading as well. So what we've put in place for our clinic is a standard around age 3 to 5 to get that lateral neck film and at least look for the landmarks. And then, you know, at that age, it's hard deciding whether MRI and sedation is worth it based off clinical symptoms or not, and severity or not. And that's a hard question to answer. But my question is, how often should you be monitoring? Or are you only looking at symptoms? Or in the more moderate or severe, should you do another one around age 10, around age 15? I know we don't have guidelines, but I also feel like we've got to start somewhere and have some standards of what we should be doing with our kids so we can learn. So I don't know if anybody's thought about that.
Question from pediatric.
I think Dr. Bober has a comment here.
Thank you. Excuse me. Really great question. A difficult one, actually. I think to some extent, we got to go old school, right? And history and physical and good physicals have to be primary. And I think if you get to know your patients and can do those physical exams serially, you're going to be able to detect.
Is it inguinal canal or pelvis?
Detect things a little bit better. So, you know, I think the topic here and some of the other ones we're going to hear about today is just, you know, OI isn't just a fracture. And what we do need to do is figure out as a community how to create these medical homes that keep going back to that, it doesn't matter whether it's a neurosurgeon or an orthopedic surgeon or a geneticist or an endocrine or a complex care pediatrician, it just doesn't matter. But you need people who are going to be dedicated to the task. Anybody can learn how to give bisphosphonates. Jeanne won't let me put a rod in, but I keep asking.
And I don't dose the bisphosphonates.
But everybody should have a role in the team, and somebody needs to be thinking about, what about BI? I mean, every exam should be head to toe. And yeah, there's eyes, there's hearing, there's BI. There's scoliosis, there's the lung. You know, you get into adulthood, we got to deal with heart valves and all that kind of stuff. And now, you know, whether it's protrusio related or just quality of life related, we have significant GI concerns. And then somebody may break a bone.
Yeah, and you know, we get high quality x-rays, and if we took an MRI of every child that had looked like they might have vascular imagination, that'd be about 40% of the kids every year. So let's go back, and being an old guy, I can say we have to go old school. I've not seen any of the kids get into real trouble who, if you had listened to them, didn't tell you they were getting in trouble early. And I think the biggest thing with centers is recognizing what your capabilities are and communicating with the centers to do. We don't do craniocervical fusions in my facility. That's not an ego thing. I mean, it's just they get better care at other places. So I think as an organization, when you're building a center, is figure out what is your capability. And if you don't have that capability, develop friendships. And Jeanne and others have done a remarkable job with quarterly meetings and things where we take our problems and we talk about them. Figure out who is it that's relatively close to you that you can work with. Because we're never going to have everything for everybody at every place.
Yeah.
So the basic quality medical home should be as close to home as you can. But I think there are going to be regional centers where, you know, DuPont does a marvelous job with the spines. Not everybody can do that. They always tell you they have a problem before they get in trouble. I don't know that I've ever seen one that said, oh, I was fine yesterday and tomorrow. But if you sit and listen to them and talk to them, they actually tell you what their issue is.
Well said.
Jill, you have a comment?
Yeah, I do. So I mean, I was talking to Jeanne, I'd tell you from my own personal experience, BI scares me more than anything. And I would say in Atlanta right now, even though we're going to be focusing on building a clinic, I think I'm probably the most knowledgeable OI person in Atlanta. And so if they're not coming to me, I'm concerned again for the community in all of Georgia. But my question, at least as of right now, and maybe we can figure this out as a community, is there a specific reason school age that you're recommending to screen? Is it more getting your baseline DEXA to see where you are to know for the future? Or is there a statistical time when you guys are seeing more BI than at other ages? And that's where more, again, or is it just all over the place? So what is it about age 3 to 5 or before school that makes you want to screen then? Because I'm also trying to be cognizant of how many x-rays I take as well.
Yeah, I mean, everybody please chime in. I think, you know, it is an age where kids can cooperate well for the x-ray. And like Dr. Esposito said before that, you know, if someone's getting into trouble, they would have told us in visits, but nothing substitutes for listening and examining. I think that's the take home.
Yeah, I see some other comments, and Mike, you can comment on this, but all mild type 1s do not to be screened for OI other than the lateral neck x-ray at some point that we mentioned. Progressive deforming types, the worse the OI, the worse the risk of BI. It's not a yes or a no. So without examining the patient and knowing that patient, you can't make a critical decision that today's the day we need an MRI. It just doesn't happen. But the spectrum has always been and will always be. And I mean, I like to say tongue in cheek, she's heard me say this many times, when all else fails, examine the patient, but only when all else fails. You know?
Thank you for a wonderful session.
Can I make one comment, Laura? That as a former Shriners physician, we had every Shriners facility has access to an EOS scanner, and the EOS X-ray dose is somewhere about 20 times less than a standard thoracic or scoliosis series. And so we have, you know, used that. There's a microdose setting that allows you to get from the skull all the way to the tailbone, and you can monitor things. It's not great for radiological diagnosis, but for actually following the progression of basilar invagination and things, it works beautifully. So if any of you have access to them, it's a great way to go to monitor things.
Dr. Franzone, I've got a question about one of our favorite topics, which is surgery. So your young adult population comes in with a femur fracture and severe protrusio. Are you prophylactically fixing the femoral neck, and when do you decide to do that?
Yeah, that's a great question. I think it really is very case dependent. If there's, we'll image them, find out where the pain is, and really case by case decision. Yeah, it's a great point, though. Always think about it at the very least. Yeah.
All righty, we're a
Thank you
little
so much.
behind. Thank you for that great discussion. Let's be back at 11:04, so you get 10 minutes. But we will try to keep on time. The next session is going to be pretty high paced, or speed dating, so to speak, with focusing on a number of resources we want you to know about. Thank you. This is the queen. We owe her so much for making this possible today. And you just have no idea what fun she is to work with. And I hope some of you who are new to us will really make a point of introducing yourself and getting to know Tracy more, so we can figure out how we can help you and how well, you know what I mean. Anyway, here's Tracy Hart.
Thank you, Dr. Tosi. You are the queen, but we'll talk about that later. I just wanted to take 5 minutes to just bring to your attention our resources that we have at the OI Foundation. I know you see we have our table in the middle there. We have the things on your table with the QR code. I don't exactly know how that works, but if you do something with that, you get resources, right? Okay. So, and our health educator, Jessica Ransom, is online. So she's monitoring the online activity today. You met some of our team. You met Melissa Bernardi, who's our director of development. You met Erica, who's our chief program officer, and Michael, our director of education, and Stacy, Loring, wherever Stacy is, our manager of grants. We're here for you. This is why we're here. So if you look at our website, all the materials that are on our website have been vetted by medical professionals, many of you in the room, and a huge acknowledgement to Dr. Francis Gloria, who has been our MAC chair for many years now and is the leader of our medical advisory council. So thank you, Dr. Gloria, for your leadership. But anything you see on our website, we have fact sheets, we have, I don't know, Melissa, if you can do a quick little navigation there. Any fact sheet you see up on our website has been vetted by probably one of you in this room. Any of the COVID resources, we have a large number of COVID resources, and they've all been vetted by Dr. Sandhouse. So we have the materials on our website for you. This is why we exist. This is why the OI Foundation exists, to help, of course, our patient community. And Michelle, we need to get together, because all those resources you're going to put together, we need to get those on our website. Michelle is one of our most popular people at our national conferences, if you can imagine. And that is a quick segue there. I want to make sure that you all know that you're invited to attend our virtual community conference, our national conference, which is the weekend of July 9th. So we would love to have you sign up, and it's virtual this year, but we're moving slowly into the non-virtual world. And this is our first attempt here with the hybrid meeting, with our scientific meeting yesterday and today this meeting. So I just wanted to make sure you saw some of the resources. Take a look through our website. There's YouTube videos. So many of you have done videos for us. We do community calls. All of those resources are prepared by you and for our community, our OI community. So I just wanted to take 5 minutes to, do that plug for the OI Foundation, to know that we're here. We are your resource. We have community members here today that are, and Sharon Mutnick is one of our executive committee board members, who would be more than happy to talk to you about the goals
foundation as well. We are governed by a board of directors. We are led by our medical advisory council. We have a scientific review committee. So we are a very active foundation and we have a wonderful community that would love to work with you all as well. So that was my 4 minutes, I guess, Dr. Tosi. There you go. Thank you.
Great. So I suspect most folks in the room have worked with other rare disease communities as well. And very often communities aren't dealing with such a broad spectrum of problems as we're talking about today. And they have pretty firm clinical recommendations. The irony is we provide information, but we don't. You saw, we just talking about BI. We're finding our way still. But one of the areas where that's basically new and very exciting is pulmonary care. And we are hoping that we are at least moving towards making some serious recommendations. So it is my huge pleasure to welcome Dr. Sandy Sandhouse, who has worked primarily with a totally different disorder, but has carried it over, leveraged it to make us ever wiser and hopefully deliver better care. Sandy, thank you for being here.
That's a great introduction. Wow. For those of you who haven't heard me talk about pulmonary issues in OI, let me just say the usual dramatic introductory pieces. One is that the major cause of death in adults with OI are pulmonary issues and respiratory failure, that there's an underappreciation of the pulmonary consequences of OI, and we're trying to learn more about what those pulmonary consequences are. One of the things that we have come away with when we have studied OI pulmonary issues is that it's not all about scoliosis and abnormalities of chest architecture, that there are intrinsic problems in the lung tissue itself, most likely due to, I'll move over if you'd like. Most likely due to collagenopathy in the lung, where type 1 collagen is the major connective tissue protein. And so we've been trying to tease out the dual contributing effects of abnormal chest architecture and intrinsic lung disease in OI. And so the question that was put to me, as you can see, is it time to make firm clinical recommendations for pulmonary care in OI? Now, we're not talking about treatments that are specific to OI lung disease yet, but we are talking about, are there recommendations that can be formalized for how to monitor for lung disease, and if lung disease is present, how to monitor whether your treatment is being effective and whether the lung disease is progressing, and what contribution someone's lung disease would have towards, for instance, surviving surgical procedures without complications. The other thing that I would add is that people with OI can get any kinds of lung disease that anyone else can get. And as any pulmonologist would do at the start of any talk, the most important thing is smoking prevention and smoking cessation. And that includes not only the patient, but their family members as well. So with that introduction, I want to kind of approach this question of what does it mean to make formal guidelines or recommendations? How does that happen? And is the OI community ready to move ahead with formalizing pulmonary and cardiopulmonary recommendations? So I'm going to talk about what are guidelines. I mean, I'm probably preaching to the choir in this group of accomplished scientists and physicians. How are guidelines developed and used? What's the evidence? What's an evidence-based methodology? And are we there with evidence-based methodology in OI? What do you do if evidence is lacking, but there is a clinical need for some guidance? And has pulmonary care in OI reached the point where a consensus guideline makes sense in pulmonary and cardiopulmonary disease? So what are guidelines? Clinical practice guidelines in general, or just clinical guidelines or guidelines, are recommendations on how to diagnose a medical condition. They are statements that include recommendations intended to optimize patient care. They are often published in major journal associated with a particular disease or organ system under rules set forward and often changed during the course of your preparation by a governing body, a college, such as the American College of Chest Physicians, a society, an association, or something like that. So how are guidelines developed and used? I know this firsthand. Clinical practice guideline development, generally guidelines are informed by systematic review of literature and evidence that's available and an assessment of the benefits and harms of a recommended approach and provide provision for potential alternative care options. Guidelines formalize recommendations regarding diagnosis and/or management of medical condition and provide information about the strength of the recommendation and the quality of evidence that's used to support that recommendation. When appropriate, alternate or minority opinions can be included in the guidance. So what is evidence-based methodology? Well, everyone knows that now because it's become the guiding principle of most medical recommendations. Evidence-based approaches generally apply to common, well-studied medical diseases and problems. So you've already gotten a hint of what the problems are in OI. Recommendations are based on an exhaustive review of the literature, and the quality of the literature is assessed and graded with respect to the size and objectivity of the studies included, the level of potential bias of the study designs and of the investigators, and the sources of funding of those studies, as well as the appropriateness of controls that the study is comparing itself to. The quality of each study is graded. Recommendations are made based on the quality and quantity of data evaluated, and the document prepared explains the methodology and the grading system that are used. These grading systems change, sometimes from day to day. The typical guideline, people get bored with it, and so associations and publishing bodies may suddenly decide in the middle of your preparation and your expensive meetings and things like that, that no, we don't want the guideline to be organized in this way. We want it to be 3 questions that you provide an answer to, which is what happened to us. And so I will talk about how that might apply to health. So what you do if the typical volume and quality of evidence is not there, but there's a clinical need to give some direction for practicing under current technology and current understanding of disease. Well, in rare diseases, this is a common problem. Many rare conditions or diseases present major challenges to the standard methodology preparing, evaluating, and publishing guidelines. If the need is great enough, some guideline publisher will allow a consensus of experts to make recommendations based on their experience combined with the existing literature. There are less formal methods for evaluating opinions of experts in place of an extensive literature review, generally under the heading of Delphi methodology, which are ways to minimize personal interactions and/or intimidation by strong personalities, and to focus on a free iterative exchange of expert opinions that gradually heads towards agreement and graded recommendations. Typical types of Delphi methodologies includes everything being done in writing without identifying who the source of the writing is, with an oversight group that knows who those people are and what they're saying, so that these the summary of what's known and the recommendations for that are all presented to every member of the Delphi group, and then the comments are made, arguments are made against one or for another argument. Those get distributed in summary form to the members. They rewrite recommendations. That all comes together, and you wind up eventually after many iterations with a document that everyone agrees on. Sometimes that means strong recommendations are watered down because there are various opinions about things. Sometimes it means that inaccurate recommendations, inaccurate in retrospect in the future, are made because that's the nature of people's expertise. Some people are more persuasive at written arguments than others and can sway the group. It's not ideal, but it's the best we've got. The pitfalls may be that they may not be accepted. That type of analysis may not be accepted by the publishing entity that you want to get that guideline disseminated to the general community. Virtually all publishing entities have developed strong caveats about including any experts with even a perception of conflict of interest. And this can be a real problem in rare diseases because many rare diseases have experts that work with a large number of pharmaceutical and biopharmaceutical entities to help encourage them to develop drugs for your rare condition, or to help with the design of studies for the rare condition, or to be an investigator for that therapy. And the winds up that when people fill out their 11-page conflict of interest statements, the publishing entity could say, well, this group is not free of conflict of interest or perception of conflict of interest. You have to find new people to be on this committee. And the response that most rare diseases have is, you want, in other words, for this document to be written by people that don't know anything about this disease, because everyone has potential conflicts in rare disease communities. In rare diseases, there are only a few usual suspects with sufficient patient populations and experience to conduct trials of new therapy, and it's unlikely that you'll find someone who has not been in that, especially at large centers that see a lot of those patients, because enrollment is key, and that's where you go to enroll subjects in clinical trials. So it could be impossible to identify authors for guidance in rare disease that have absolutely no conflicts of interest, which is the usual criterion for accepting someone into the expert panel. So I'm going to talk about the guidance that I helped put together for the alpha-1 antitrypsin deficiency community. We convened a writing committee to prepare the first guidelines for alpha-1 antitrypsin deficiency in 2000. It took 3 years and about $70,000 of the Alfred Foundation's money in terms of travel expenses and hotels and hiring librarians, things like that, to bring the various writing groups together and have the resources that they need. The writing group identified 693 references that were felt to reach the standard of review to be included in the guidelines. Each of those references in the document is summarized and graded, and recommendations were assembled after multiple meetings with separate writing groups for lung disease, liver disease, other diseases, genetic counseling, and various other topics. The resulting document was 81 pages long and was approved by the American Thoracic Society, the American College of Chest Physicians, the National Liver Foundation, the European Respiratory Society, and the American Association for Respiratory Care. And the publishing journal, the American Journal of Respiratory and Critical Care Medicine, the Blue Journal, as we call it in pulmonary medicine, refused to publish it as a guideline because they said that there was too much conflict of interest among the authors and that it did not have sufficient evidence to be considered a guideline. And so what happened? They eventually did publish it. On the left is the front page, where it's not called a guidance, it's called a standards document. It's the standards for the diagnosis and management of individuals with alpha-1 antitrypsin deficiency. You have a glimpse of the table of contents of the guideline, and the last page is the number of people it took to prepare the document that was eventually submitted and published in 2003 as the first guideline document for the standards document, excuse me, for alpha-1 antitrypsin deficiency. We were able in 2015 and with publishing in 2016 to actually create a clinical practice guideline for the diagnosis and management of alpha-1. We put together essentially a Delphi methodology group that went through the full Delphi program, and again, sponsored by the Alpha-1 Foundation. And we made very specific recommendations. We graded the strength of that recommendation and the strength of the literature behind that. There are a large number of recommendations that were very specific, that had a category A, strongest recommendation, and weak evidence to support that. In fact, we have a whole litany of who should get the therapy that's available to augmentation therapy, broken down by various levels of pulmonary function, all with strong recommendations that the therapy should be given, but with varying degrees of strength of evidence because of the varying criteria that enrolled patients that studied that therapy in that particular population. So that's what the unsatisfying nature of making strong recommendations in rare diseases. As you can see, this was published in 2016. So has pulmonary care in OI reached a point where a consensus guideline makes sense? Well, I have to ask the question, when would it be appropriate to publish? When there's sufficient evidence or expert opinion to conclude that such a publication would improve the diagnosis, follow-up management, or outcomes in OI. Have we reached that point? There is likely sufficient understanding to recommend that routine and repeated testing of lung function and our chest anatomy over time will be beneficial to the health of OI individuals. There is an underappreciation of the pulmonary issues associated with OI among the broad group of healthcare providers who might be following these patients. And there are likely a sufficient group of experts to constitute a writing committee. So what would the next steps be if we were to decide that that was something we want to go forward with? Well, assuming all of this, if there were a decision to consider writing pulmonary guidelines for OI, an exploratory group should be constituted, an approach should be made, an appropriate journal or organization, a plan for the writing process should be developed, a plan for the literature or expert opinion methodology should be formalized, and then full speed ahead for 3 years, and you've got yourself something you could potentially submit. And I'm going to perhaps surprise you and say that my opinion is that we're really not ready yet. The data that I've presented and that's been generated by people at Hospital for Special Surgery, Columbia, soon Cornell, Joan Marini's longtime interest in pulmonary issues in children and young adults with OI. All those things are in their early stages of generating data. Our study at Hospital for Special Surgery has in its title that this is a pilot study. And pilot studies are what you do before you start the real study. You identify the issues that need to be studied in more detail and you move forward. So I personally think we need to await the conclusion and publication of the studies that are currently underway, and perhaps even embark or even finish the studies that the pilot studies suggest should be done to learn more about OI. We need to learn more about both evaluation and treatment of pulmonary issues in OI before we can make the kinds of recommendations that are going to affect the care of people around the country and around the world. But I'd say that it's not too early for the OI Foundation to make some informal recommendations, as we do in many other aspects with the OI Foundation, of the care and health of OI patients. And so I think that we can come up with routine monitoring pulmonary pulmonary status. And I feel that that's important enough to do, that it's something that the foundation should embark upon with the goal in the future of creating formal guidelines. Others may disagree and want to embark on it now. Because the writing process is so long, there may be additional studies and additional data published by the time you're ready to finalize the document, but it's always hard to go back in retrospect and start to modify the recommendations based on something that comes in late in the game. You surprised that I said older. So what would these recommendations that an expert panel could publish through or present through the OI Foundation look like? Well, consider providing routine monitoring of lung function on at least an annual basis in all those diagnosed with OI. That should include complete pulmonary function testing, not just spirometry, but also lung volumes and diffusing capacity, routine oximetry, and if it's abnormal, get a blood gas, a measure of exercise capacity, whether it's a 6-minute walk or bicycle or a 6-minute hand bike or whatever kind of exercise that's tailored to the abilities of a given individual. It's important to appreciate that longitudinal comparison of these values is much more important than the actual individual test because of the problems in normalizing values in people that have short stature. And so it's much more important to see the FEV1 declining at a rate greater than expected for an adult, normal adult's declining lung function over the years. And the calculation of predicted normal values, if you use those, should be considered to be broad estimates. And if used, they should be calculated in exactly the same way every time you perform these tests. In other words, if you're doing point-to-point arm span in place of height, you have to use that methodology every year that you're doing those pulmonary function tests. So there needs to be, in an OI pulmonary function report, a specific comment on how the height was determined. If a CT scan is performed to evaluate the spine or other bony structures, make sure that pulmonary windows are included. Because I've seen, thanks to the study at Hospital for Special Surgery, all these great spine films where the lungs are simply black. And you can't make any judgment about it. And in fact, the radiologists reading those films don't comment on the lungs because they're actually not the appropriate films to look at lung tissue. So it may be that every now and then, when something changes that isn't explained by these other tests, you might have to do a specific lung CT. Because that seems to be the only way that we find out the kinds of details that Joan Marini is describing in her children and young adult study, and that we're seeing in our study at Hospital for Special Surgery. For those of you who haven't heard that, our main unusual finding was that over 90% of OI patients, regardless of how severe their lung condition is, or even if they are normal, have bronchial wall thickening. And that was an entirely unexpected finding and suggests that there's some abnormality of the connective tissue or there's inflammation in the airways of patients with OI. Also, a cardiac echo and EKG are recommended for any individual with a history that might have a symptom explained by cardiopulmonary disease. Because we all have seen patients that have valvular problems, that have issues with ejection fraction, things like that. And if you don't do the studies necessary to hone in on the etiology of those abnormalities, then you're doing the patient a disservice. So, is it time to make firm clinical recommendations for pulmonary care in OI? And my opinion is perhaps. So, happy to answer any questions.
Thank you so much, Sandy. Are there questions? Our main goal here is to make you aware because pulmonary doesn't come up in all different kinds of environments. And yet it's turning out to be so very, very important in the aging well aspects of OI. You may have seen, if you subscribe to Breakthrough, the quarterly magazine from the OI Foundation, write-ups about the Jamie Kendall Foundation. And it was Jamie's untimely death that really set this in motion. And we have to give credit to that patient-based effort that raised the money to make this all happen. And we have a lot to learn, but our goal here today is to mostly ask you really to be sure that you're exploring the pulmonary issues in your patients and identify them when they're there. I now have kids I wouldn't have imagined on rescue protocol, not that I developed, but that my pulmonary colleague has developed to be sure that they get through the winter and the flu season, et cetera, safely.
Yeah, I hope I've also convinced that as you take a team approach, a member of the team should likely be a pulmonologist. Get them informed on what OI is and what the issues are, and get them interested, because you may need that man or woman to assist in the care of the patients. Also, we've put together, after Jamie's death, we put together a brief information page about what things OI patients should be concerned about if they're undergoing a medical procedure like a colonoscopy or something like that, to make sure that those things are as safe as possible.
Thank you, thank you. Okay. We now have a bunch of topics we're going to cover very briefly. And one of the things I particularly hope to engage you in is the OI Foundation Registry. This has existed in some form or other for over 20 years, but we historically wasn't used all that much. It was initially part of the National History Study, and that actually the NIH gave up on it, and the good Tracy, as always, held on to it, and it's turned out to be a wonderful resource for it. And some of you, either yourselves or with graduate students or whatever, may have some questions, and we want to urge you to use the registry. Our only requirement at this point, we keep talking about having a board of directors, that sort of thing. All we ask is you contact the foundation with your IRB approved project. The registry is housed by the University of South Florida, and they will also put it through an IRB. And I'm happy to tell you that, unlike mine, they're really fast. Just to tell you who's in there right now, the great change is we used to be about 80% women. We're getting a better mix now, 64% women, 35% male. This is weird, but one of the problems with the natural history study is it's dominated by young patients. And if you look at this, it tells you literally the number of patients we have in each 5-year cohort. And notice that we have a significant number of adults as we look at answering questions in adults. If you subscribe to Breakthrough, you'll see how during COVID, we've taken advantage of this. So we've just recently completed our 3rd survey of the community on what's going on, and just a little bit of the data that we got. I'm happy to tell you that only 31% of our respondents had COVID. But the big number there is that Tracy and I are only aware of 2 people who died. For all of our fears about the pulmonary issues of COVID, partly I think because our community was so good about self-isolating, but we haven't lost a lot of folks. Already 84% of our folks are vaccinated, and 68% have received at least 1 booster. If you're having trouble convincing patients, what you can see in those next diagrams is If you were vaccinated, your chance of being in the yellow, hospitalized, very small, only one patient, versus among the unvaccinated, you notice the yellow is much bigger, that we had far more hospitalized patients. We want lots of folks to do this. So now I'm going to invite Jill and to talk about her experience using this, and then Deb Krakow is going to make a little advertisement, I hope.
So this is not just my experience, as you guys can see here, representing an incredible group of people that worked with us on this. And so again, my disclosure, I'm a pediatric orthopedic surgeon. So we had just some very specific different questions that we solicited the OI Foundation to help us with using the registry to get some answers. And so we titled the study OI Wish. And we generated a 12-question survey to help the OI Foundation. And we called it, I wish orthopedic surgeons had better strategies to help with. And then we had just some very specific questions that we asked the community. And then it was electronically administered by the OI Foundation through the registry. And these are just some slides, and I'm going to just discuss with you the details. But we had, I think, over 330 people respond, so a pretty good mix. There were definitely some flaws that we learned about how we administer the survey. It's mostly what Dr. Tosi alluded to. You know, as pediatric people, we wanted to learn about more of child care, but most adults answered those questions. But I still think it elicited some really good information. And so if you look at the green, those are the things that families found most important to them. And I'm going to show you that better on the last slide. And then we actually even had a free response, which this was the graph I made, which was here. And what we did with all the free responses, we read through every single comment that the families had. And some of them were like, if you see other, it's 40%, I couldn't categorize them. Some of them were like, you guys are awesome. Thank you for doing this. Some of them were of, we can't get OI care close to home. We go here and they're great. So it's really hard to classify those. But in the ones where I classified them, so whether they wanted to talk more about spine research or rotting surgeries, just try to create themes, that 15%, that's in looking at adults. So many patients or people in their free responses said, please help us learn more about adults. Mental health, I'm surprised, only had 5%, at least in their free response answers, discuss that, and pain management. But again, when that other slide that I had before, when you look at the theme of what patients are asking us for, really it's pain management. I mean, as surgeons, we're always thinking they want us to do better surgery, but they just want them to feel better. Mental health management. And then obviously the big one is improved OI, adult care for OI. And again, in learning from this, we're starting to work on creating adult orthopedic surgeon task force, identifying surgeons that are in the community. First, we're going to start with fracture and trauma care. And then I specifically have a goal to talk to some arthroplasty surgeons as well and see what we can do to try to help out our community, because that's what they ask us for. So I think it's a great resource and I encourage you to use it. So.
We're so hopeful that more people will start to use the registry. And as you can see, we're really begging you to ask your patients to sign up. I saw Deb. There you are. Oh, you great. Super. You don't have slides, right? No. Yeah.
Yeah, okay. So I just want to echo what Jill said. It's a great resource if you have particularly questions about adults. And so we did a pregnancy survey and we're able to get back 132 unique pregnancies. We are doing a follow-up survey where our IRB is going to allow us to contact people. So they're going to fill out the survey. And part of it is, if you answer any questions right, can we call you? So we're working on ways of getting better and better data, right? Because, you know, surveys are, you know, sometimes the invitation to the unhappy or unsatisfied. So we want to use this registry and keep learning from it in a way that we can sort of get better and better data. So, some of the issues, but if there's anyone out here who wants to work on sexual health, menopause, any women's issues, please come talk to me or the OIF. It actually is the hardest part, is just getting your IRB to do it, to get your IRB. And once your IRB in, is the OIF has just been incredibly helpful and gets the surveys out. And it's really an amazing wealth of information. And questions can be answered that we can't do individually because there just aren't enough numbers in our practices. Rich?
Oh. And the OI Foundation will help. Absolutely. Yeah, we want people to be successful. And I think the issue, there's collagen everywhere. That means there's problems everywhere, or questions everywhere. And we want to help answer them.
I just asked the question for the fledgling OI clinics, who they should contact to help navigate the IRB process at their institutions.
It's always hard because every IRB has their own challenges. But I think the basic standards for surveys, since they are de-identified, it's easier to do than it might be otherwise.
We can, and I'm happy to, I send any one of you the surveys that I'll send any one of you, like the pregnancy survey that we built, so you can see the list of questions and you can do it. I will tell you areas that are underrepresented. We've had no surveys on ophthalmology, on eye findings. I mean, there's so many things to continue to survey patients on.
Absolutely. All righty, we're going to get him to his plane on time. One of the great excitements for us is the natural history study. And although the sites are defined, in fact, sub-projects aren't. So Reed's going to talk to us about that.
Thank you, Laura. So as Laura mentioned, I'm the co-PI of the longitudinal study for the BBDC, along with Frank and the clinical team liaison for the study. And so Laura just asked me to real briefly talk about pilot projects. I'll also talk about a couple of other opportunities really quick. We do have annually an opportunity for individuals to submit proposals, pilot projects to the Brittle Bone Disease Consortium, the BBDC, for consideration. There is a relatively small amount of money that is budgeted every year to help support those. Usually, like generally the money that we get from NIH for the BBDC, it's not going to support everything. Usually people would propose, but it would support that. You can propose projects that would utilize existing data from the longitudinal study, or you might propose to add something to a longitudinal study, or those sorts of things. There is a process that we have for this. If you're interested, you can certainly contact me, or from the BBDC landing page, you should be able to find the project manager, Diane Nguyen, and there is a very small amount of paperwork. It's about, I think, 4 or 5 page application, most of which is just some basic information, and then about a 2-page summary of what you're proposing for the pilot, if people want to submit. We actually have it open right now. So if you've got something and want to submit it in the next 2 weeks, which I know is short notice, but it again is an annual cycle that usually, again, kind of right about this time in the early spring that we accept pilots. I should also say that the data is available. So, but before I say that, let me say that many times the pilots can evolve into a larger study. So the dental and craniofacial studies that were proposed as pilots in the initial BBDC have now evolved into full projects. And so again, just to let you know that if you propose a pilot project, even if it's small, it may be that, you know, if it's very successful, that could be rolled into a much bigger project within the Brittle Bone Diseases Consortium. And then finally, just to say that even outside of the pilot project mechanism, you can propose to at least kind of look at longitudinal data. So again, if there's data that we've collected in the longitudinal study and you have a particular idea of something that you would like to look at, you're welcome to contact us and to submit a proposal. Certainly there are things established that people are currently working on, like the scoliosis study or the cardiopulmonary pilot that Drs. Raggio and Sandhouse have. So we are mindful about competing, but as long as it's not kind of competing with something someone's doing, we're certainly happy to entertain and are supportive of that for individuals. So I will, and again, like you're welcome to contact me or Diane Wynn about those opportunities as well. So I'll happy to stop there and see if people have questions.
Thank you very, very much. He will be here for a big 10 more minutes, but we will get him to his flight on time. But if you have been thinking about a pilot, remember we now have 937 people in the longitudinal study with a ton of data. So there really are some opportunities here for data analysis on things we haven't thought about.
And just to be clear, longitudinal data. So again, for many individuals in the study, we now have 4 years worth of longitudinal data for, patient-reported outcomes, measures, DEXAs, all those sorts of things.
Great. Thanks so much, Reed. And now, thank you. Our next speaker is Frank Rausch. Do you have slides, Frank? Yeah, okay. I think the TeleECHO experience has been an extraordinary one for us and opened up our opportunities for learning and sharing. And Frank's going to talk OI TeleECHO.
Okay, thank you. So just a couple of slides to introduce you to the OI TeleECHO if you have not heard about it. So this is managed by the OI Foundation, and the driving force really is Michael Stewart. So you may have received his emails. Maybe you just clicked on them for junk, but it's not junk. It's actually very interesting, and you can register for each of these TeleECHOs or for the whole series. So just take the emails from Michael seriously. So this is what we have as a flyer for the OI TeleECHO. As I said, Michael is the organizer. The contents people are listed here. So Jeanne, Franzone, Sandesh Nagamani, and myself, we had made this list of topics and invited people. So and here's the people or the topics that we have already dealt with. So each month there is one webinar that takes an hour. First there is a presentation and then a question and answer session. People can present cases at the end. It's on a specific time, like the second Wednesday in the month or something like that. And so you just have to register and then you can participate. So we had 12 sessions already. The next session series will start in fall. And we will inform you about that. And the sessions that we have already had, they are accessible on the OIF website. One of the other great things about the OIF website that Tracy didn't mention. So it's under the research button. There is the OI TeleECHO, and as a free bonus, you get many of the presenters in hiking outfit. So we will start again, but the 12 sessions that we had, you can already look. It's like a YouTube video that you can access from that website. Okay, thank you.
Thank you, Frank. And for all of us, getting CME has gotten harder. And the CME is free, a wonderful thing. So don't forget to sign up for that as well. Next, the good Dr. Bober is going to talk to us. I hope everyone has seen the new Diagnosis Toolkit in the back of the room. And here is its originator,
Co-author.
co-author, all right.
All right, well, thanks for the opportunity to be here and talk about this book. And really, I think this book is part of a larger set of resources. I can do orthopedics. My wife streams. I know. Since COVID, I've taken to wearing scrubs every day, and I often get confused for being a surgeon. Okay. I missed that. I'm trying here.
Hopefully they can hear it online.
All right. So disclosures are all in the wrong categories. So, I've been interested in OI. My first exposure to OI, as I think about it, was really close to about 30 years ago as I was a graduate student and I met a family. And about 10 years ago, I met this child and this family, and they have taken my path, if you will, and shifted it very much into the NICU and into care that begins prenatally and how to take care of those families at the earliest stages. So this is a young man that was diagnosed from an ultrasound, I believe around 20 weeks, and was told that the mom was told that the baby had no chance of survival. And she came to me and she said, I want my baby to survive. You have to do everything. And we said, well, we'll do what we can. And as this was happening, at the same time, this was happening. So that's me with my micro preemie son, who was born weighing about a pound and at 26 weeks. And looks like she just walked out, but I want to publicly say thank you to Debbie Krakow for her support during this time. But as I lived this experience, I realized how many tools and how many resources the NICU had that we didn't have back in 1979, when Dr. Solen said, the second most common category of patients that I see have lethal OI. And we thought long and hard about how we could bring those tools to bear. And here you can see that child 5 years later doing well. And what we want to try and do, we, the OI community, and it's, to use Tracy's words, which I'll show you in a minute, the OI family, is we want to be able to bring people into our family with setup as much as possible for success. So this is, again, the OI website page. There's the new diagnosis, and this is really a team or a combination of resources. This navigating the new diagnosis is only one piece of that. We saw the fact sheets, there's publications, there's videos. With Jess, we've been making YouTube videos to try and verbally go through parts of this book. These are other publications that are there on that page. The contributors to this book. There's a lot of people that contributed to creating this book. And then, like I said, I have Tracy's words here, which is congratulations on your new baby and welcome to the OI family. And I think that's, Rich Cruz says it all the time, is we're a family. We're a family of care providers. Our patients are part of our family, and we need to work together. So I think it's really appropriate that she used those words. We start the book by talking about myths and facts and just trying to clear up some misconceptions before we start teaching. We talk about the clinical types. Notice that we did not use the word lethal, but rather most severe. And then there's different scenarios that the book plays through depending upon where you are. Could you be expecting a parent, an expectant parent of a baby with OI, with no family history, with a family history, etc. And then you get these 4 scenarios, and it tells you which parts of the book could be a resource for your scenario. This is an important piece, especially if it is diagnosed in utero, building your prenatal team. And there's a worksheet there that I cut on the bottom so you can put the names of people. Get organized. Who's the neonatologist? Who's going to be the nursery staff? Can you meet these people? Can you have discussions? And what do they need to know? Well, that's all in the book. Presumably, we get home. There's information here about handling and car seats and feeding and fracture care, mental health support. Again, there are podcasts that are aligned with different aspects of the text. So it's really a comprehensive resource. Different types of pain management strategies, different information about therapies, information to share with your doctor. This is what, we talk about OI as, some of us say it's a rare disease, some of us say it's a common rare disease, but regardless, the typical pediatrician sees about 4,000 children in their practice over a lifetime. And we are not 1 in 4,000. So the likelihood that a family is going to take a child with OI to a basic pediatrician that's ever had any exposure to OI is highly unlikely. So we need to make sure that they have the kind of resources that they need, so to be able to bring information to the doctor, especially information that's vetted, is helpful. And then this is a latest update on our child. This is from last week. This is him standing in the pool at 10 years old for the first time ever bearing weight. Well, it took a team, but it took that mom to push through the system, and he's doing great. And it's a family, and we're really happy to be part of that family. We just published 2 papers that specifically talk about how to deal with NICU care. And anybody that has any questions, you can reach out to me through the OI. I'm happy to try and talk through this, because babies are born locally. So this is an important thing to try and get our kids off to the best start possible. Thanks.
Great. Thank you so much, Mike. And we have copies in the back, and I want to be sure you have them ready to share with your families, that's for sure. Just such an effort. I'm so grateful. That's for sure. Yes, Tracy. You need a microphone. Wait one second.
Thanks, Michael. I really wanted to thank Dr. Bober for his leadership in putting this together. It's our most requested resource right now, and it's just so valuable. So thank you, Dr. Bober, for your leadership. We appreciate it. And then I just wanted to comment really quickly too on the team that you saw that was up there. Many of the folks on there are community members, OI community members that had, the patient voice was present throughout the entire development of the project. And you were fantastic in including that patient voice. So just wanted to add that.
Great, thank you. Now, last but not least, orthopods. Most of us practice in isolation. My other colleagues in my practice have no interest in OI. I think that the DuPont team is particularly lucky because they have a whole bunch of people interested in OI. And one of the great resources that have been developed is the surgical case conferences. that Jeanne, Megan Wallace, and Jill Flanagan, I always want to call you Flanagan, I'm so sorry, Kaplan. I can't even remember what's your married name today. This is a bad sign. Flanagan's married. Okay, thank you. I'll get it right eventually. But again, showing the power of the internet, the power of Zoom, and the power of, or the ability to lift all the boats.
Thank you. Yeah, well, we're pulling up the slides. I think a common theme here is there's lots of forums to share cases, and those of us who just love doing OI and love the challenge of it really enjoy the process of learning. Frank mentioned the TeleECHO series, and that should be a case-based forum. So please, for other cases, submit them for those sessions. This is more specifically an orthopedic forum, but as Dr. Tosi mentioned, Jill Flanagan and Megan Wallace and I started this really right towards the beginning of COVID, and we call it an OI Surgeon Quarterly Case Review, a virtual forum. And really it is a forum for surgeons with an interest in OI surgery to get together virtually in a safe environment, review completed cases or discuss upcoming cases, demonstrate a learning point that we can share with others, seek advice on an upcoming case is probably the most common reason that folks will submit cases, and really discuss the detailed aspects of OI surgery that fascinate us. We take it very seriously that it's a respected environment so that we can discuss challenges and complications, and also an inclusive environment. So please, if you have an interest, or if your colleagues at your institutions have an interest, please let us know, and would love for you to jump on board. Even if you can't come to all the sessions, would love to have you. This was, I think this was the first or one of the very first times we met, and I love these screenshots because it's really a range of surgeons in all different spots in our career. We have Dr. Fassier here, we have Dr. Esposito on here, we have Dr. Cruz. We have Dr. Hamdi. We have, so many colleagues in different stages of the career. Dr. Tosi, I don't think you had hopped on at this point yet. Oh, you were on incognito as LT. I love it. Don't worry, you're in the next one. Here we are again discussing a case, and everybody's very engaged and plugged in, and it's just become a nice way to learn together. This is an example of a tough elbow in a patient with type 5 OI we reviewed together. Here's a challenging non-union and osteoporosis pseudoglioma patient. Example of a bent telescopic rod with a distal humerus fracture. We know those are a challenging spot, and really discussing the nuances of that. This is an example of a case Jill had presented during a recent meeting. This is a young adult with a static locked intramedullary nail in place. The nail had broken at the site of a non-union. So many nuances of both working this patient up preoperatively and meeting the decision-making intraoperatively that we enjoyed working through as a group. This was the same patient's upper extremity, a challenging site in the ulna. And sharing the post-op course here, as well as the post-op course for the realignment and rodding of the ulna. And this is 2-month follow-up here. And I think this case is fascinating because you might have deja vu. Just a couple weeks later, Dr. Cruz and I did a case that looks remarkably similar. And it's great to have this environment to share and learn. So we approach this in a similar way. And I think that brings up a key point in that when we share cases, we review them, the follow-up is absolutely critical because that's really how we learn from each other. And, as we all know, and I've learned well from Dr. Cruz, nothing cures confidence like follow-up. So that's really where we learn well. The next Well, as of right now, we have 33 surgeons on the list from 22 institutions. Our next meeting tentatively will be May 18th. We usually do them in the evenings from 8 to 9 p.m. Eastern time. We really welcome participation, and thanks, Dr. Tosi. You've been part of it from the beginning, and we just love having you there. So thanks.
And I assure you, thank you so much. I assure you, I appreciate the good ideas. And so for those of you who are new, your surgeons may not know about this CAFES conference. And this is a really wonderful opportunity. Even though we go off to the POSNA meeting, Pediatric Orthopedic Society, OI is a minuscule part of that meeting, and the opportunity to focus on these incredibly difficult cases is so magical in terms of improving our outcomes. So we hope you'll share that. So we're going to do a quick another break, and we'll look forward. Whoops. Yes, that's a good point, though. Before we take our break, because we're miraculously a minute or two ahead, does anyone have any questions, requests, demands? Okay. Then we will see you back promptly at 11:15. Thank you. No, wrong. 11:30. Sorry. Thanks so much. Ready to start our last session. Just a couple of things. I have had a couple of different opportunities. So Merlene, would you stand up, please? Merlene Jose has come all the way from Hawaii to join us, and she's from the Shrine, and she has requested with the other Shrine people at the end of the session, please introduce themselves because she doesn't know you. Can I quickly get Shrine people to raise their hand? Yeah, see, you've got a lot of friends here, and she would love to get to know you. She wants a picture. All right, that's also fun. Definitely fun. And then I just, the great thing about Zoom, on here, wherever you are, my dear, Ingrid, I'm all the way from Europe for our wifey partners in Europe. It's great to have you. There she is, Ingen. Hopefully you'll find a lot of things to share. Do you want to unmute and say hello real quick?
Hi, everyone. I've been listening in the whole day, and it's been really, really interesting. I think you have found very new and innovative topics. So just looking forward to the follow-up. Yes.
Great.
Thank you for letting me be here.
Absolutely. We're thrilled. And so next, we still have a ton of stuff we want to talk about. Our next speaker is at home at the OI Foundation, and Jessica Ransom is going to give us a few minutes on current OIF activities and resources. Thank you.
Hi, everyone. As Dr. Tosi said before, my name is Jess Ransom, and I'm the health educator with the OI Foundation. As the health educator, I am the main point of contact for community members and the OIF Information Center. And essentially, I'm constantly indirectly assessing the needs of community members. And the way I describe my role as health educator is bridging the gap in between the need for resources and information for community members. The OIF Information Center receives over 11,000 requests from constituents each year. The Information Center can be accessed by phone, email, mail, fax. We even receive questions through social media. We just want to hit community members at a plethora of avenues where they can contact us. Today, we often receive handwritten letters from community members in search of information, and we also still send information via mail. As far as constantly, indirectly assessing the community members' needs, if I am receiving mail from community members, that tells me that there is a pocket of community members who would like to still receive resources through mail. So that's something that we keep in mind when we are developing resources. On the other end of the spectrum, we have developed virtual office hours, which are available through Zoom every Tuesday and Thursday, where I am available on Zoom for people to ask questions. And another facet of virtual office hours is this was born during the pandemic. And, I would get phone calls or emails from community members that didn't necessarily have questions or inquiries for me, but really wanted to talk. So this is a space for connection as well. Another facet of the Information Center is there's available online, and we have a ton of video resources. The OIF Information Center is constantly undergoing resource development. As you heard Dr. Bober discuss earlier is the Navigating a New Diagnosis Toolkit. And again, when we develop our resources, we're constantly assessing the needs of community members. This resource can be mailed to community members, and it's also available online via PDF download. The toolkit is made for community members to take this to appointments. So it's really a workbook style where it's interactive, where they can write within this resource. And there are different call outs for the podcast series, just a really interactive resource. As I said before, with resource development, something that we keep in mind is that this is a toolkit. So the thing about a toolkit is that we're constantly building. So as Dr. Bober said before, we are launching our video companion piece to the toolkit. So just really trying to hit all modalities. You may have some community members who want the tangible resource, but then we also have others who may benefit from more of a video format. One of the most common types of inquiries that we receive at the OIF are the requests for medical professionals in their area. And a direct response that we have to this is with the Information Center is the clinic directory, which is available on our website. It's really a one-stop shop where community members can see the list of clinics throughout the U.S. listed by state, the name, the website, phone number, and whether the clinic accepts children or adults. Another facet of the OIF Information Center is the COVID-19 toolkit that we discussed earlier today. All of the recordings of the COVID-19 Q&A calls are available within this resource. And again, we're really big on making things a one-stop shop. The COVID-19 toolkit is one of the first things that you will see on the OIF's website. And essentially, whenever the CDC makes an update and it specifically pertains to the OI community at large, we will then update our resource within that same day, sometimes within minutes or hours. Also within the toolkit, we have a vaccine file from the CDC where people can go in and search for vaccines in their area. All of the COVID-19 survey results are located within the toolkit as well, really a snapshot of them and so much more. Some other OIF activities and resources, really just honing in on staying connected. We have OIF virtual support groups. Those are a lot of fun. We have developed the Mutual Support series. Mutual Support is a main component of the OIF's mission. We've done New Year's Eve extravaganzas, Friendsgiving. We even did a Halloween party for the kids. So just really staying connected. Also, we have the virtual national conference up July 9th. And in the summer, we will be doing regional conferences again. Another resource that we have is Gemma's Corner, created in honor of the OIF's founder, Gemma Geisman. And it's a place where community members can share OI story. And this is posted on the OIF's YouTube page. Another resource that is pretty popular is the Jeanne Coleman Impact Grant Program. And essentially with the Impact Grant Program, community members can apply, and if their application is chosen, we will pay for whatever resource or item that the application was approved for, and it's completely covered, and community members won't have to won't come out of pocket for anything. You've heard me use the term community member, I'm sure, many times throughout this presentation, but I just really want to focus on the community aspect of it. I will not only receive inquiries from those with OI, but I'll also receive inquiries from other helping professionals as well. We encourage members of the medical professional community to reach out, our teaching community. We've had lawyers reach out, really just focusing in on the community aspect. You heard the term family used earlier today, but really just staying connected. All right. OIF resources for medical professionals for the Information Center. We encourage everyone to reach out, as I said before. One thought process that I have is that the OIF Information Center is equally important to medical professionals as it is to members of the OI community. Some of the questions that I've received are, I'm looking to connect with other OI experienced medical professionals. We can facilitate that connection. Do you have any events specific for the medical professional community? Yes, we do, and I can connect you to those events. I have a patient who is looking for financial resources. Can you help with that? I can. I will connect you with the Impact Grant Program. Another question, I have a patient who is looking to connect with other individuals with OI. Yep, I can help you with that too. And we can also facilitate consultations with OI experienced medical professionals, if you wanted to connect about an upcoming procedure. I am going to just stop here for the purpose of time, but the main thing that I really wanted to get out about, these resources and activities is to reach out to me. I can help connect you with others in your field, or if there's something that you are constantly seeing at your clinic and you believe that there could be a resource for it, we can work together to develop these sort of resources. I am going to put my contact information in the chat, but the last thing that I just want to leave you with is that the OIF as a resource is just as important as it is to members of the medical professional community as it is to members of the OI community. One of the reasons why this is one of my favorite events is that I am surrounded by members of the medical professional community. As you can imagine, one of the most frequently asked questions from community members are for medical professionals in their area. So I'm sort of going to do a call to action for those of you that are in person and online. There is a QR code at your table, and it's just asking you to scan it and set up a time to connect with me. We just creating that community environment and working together so that we can bridge the gap. Thanks so much.
Thank you so much, Jessica. Now, in life, there's always an ask. And so to a certain extent, the next session is both informative and an ask. I will be honest. And the good Sharon Mutnick and I are going to talk to you about one of our ongoing projects on transition and adult care. Great. And I'm going to describe it, and I'm going to try to recruit you to give us a hand. Great, thank you so very, very much. So, as I've alluded to earlier, I've been doing this a long time. I live in a state of amazement about how things are changing, how things are getting better. And I've also found, just like everybody in this room, we all see OI just a little bit differently in terms of how we prioritize and what we try to do. But I think we can all agree that one of the biggest gaps we have out there is making a smooth transition for our kids into adulthood and making sure that our adult patients have good access to high quality care. So a big question is, how do we develop a strategy that will both capture this rapidly changing story, not just for today, but for the long term? As I mentioned, we were so excited in in 2019 to win our first PCORI award, focusing again, what do the patients want? And I'm thrilled to tell you we have yet another one that technically started in November and is going to run for 2 years. It has one of these long-winded titles, Preparing Adults with OI to Engage in Research on Access and Quality of Care for Their Rare Disease. But we're really just working on 2 issues. One, as I said, improving transition and making sure we get the best quality of care for all OI adults. What are we going to do? We want to talk to everybody. So we are going to reach out to you and ask you both to get clinicians and researchers from your clinics to talk to us. Also, introduce us to patients who might speak to us. We want to be sure that we get the full spectrum of the OI community, particularly people from underrepresented communities, and if possible, folks who are disadvantaged by the digital divide. If we don't serve the entire community, we failed. We want to see what are the gaps and what are the opportunities? What are patients open to? As Dr. Sandhouse alluded to, they have patient coordinators helping people navigate through the challenges. Is our community open to that? What are some of the new ideas for what we might do? We are going to interview, by the time we're done, several hundred people because we really want to be sure that we've touched on every aspect of what the community cares about. Our goal is to create a strategic plan for the OI Foundation that capitalizes on these findings, and at the very least gives a roadmap for what we might do going forward, and hopefully even gives us good enough data and ideas that we might even apply for greater grant funding. So this is a giant step. And most of us, myself included, come from children's hospitals. It's much easier. I just have to walk down the corridor to collar the consultant I need. Much harder when I'm trying to help my adult patients coordinate care that's of high quality. This is a big challenge, not just for us, but for other rare disease communities. But what can we do perhaps to take the lead and make things better? And Sharon, can I get you to speak to that? Let me turn it on for you.
Is this on? It is. Hi, everyone. So I'm Sharon Mutnick, and I serve on the board of directors for the OI Foundation. First, I want to thank all of you for being here. You guys are truly my rock stars. So thank you. From the board perspective, I just want to reiterate our support for this PCORI initiative, and we are confident that this will help improve the quality of the life for our community. And selfishly, as a member of this community, I have ulterior motives here. So I want to just share, I also serve on the patient advisory board for this PCORI project. So some of the things we've discussed in talking about what type of survey we want to publish, what should be some of the questions, come from our experiences as we have already done that transition to adult care, some well, some not so well. In looking out and hearing like the discussions over the past 2 days, I realized the care I'm actually lacking in my own life. But I also am the parent of a 21-year-old who is going through this transition into adult care as well. So this topic is vitally important to me, and developing skills for our community will help not only with this initial transition to adult care, but throughout life as you move to a new city and you have to find a new team, or as you age and are going through, life changes like menopause or geriatric care. I have a father who is 86, turning 87 this year, and he has type 4 OI as well. So it's just the broad spectrum of adult care is so near and dear to my heart. So selfishly, I'm happy to be part of this project. And if you or anyone has any questions about this initiative, I'll be happy to address that.
Thank you. As I say, if you, yes, if we really want to interview a lot of people because everybody sees things just a little bit differently. Like that, we had the elephant. Depending on where you are, you're going to see this problem as differently. And as I alluded to, one of the challenges is we're dealing with sometimes very near and dear private information. What kinds of methodologies would help lift all the boats without having people feel that their privacy had been interfered with? So it's a tough go. I just wanted to spend a minute to thank Tracy, Hart, and the entire OI Foundation staff. I write these grants, but let me tell you, they do the work, and I am beyond grateful. And thanks to them, we have a reputation for completing our projects, meeting our deadlines, and doing a good job. And they're even fun to work with, even though we have all these deadlines. So this is actually our 4th PCORI award, and it shows what a good team can do. So I am just beyond grateful and hope to engage as many of you in the interview and thinking process as we possibly can. All right, so that ends this topic. Great. Now, our last main lecture for the day, last but definitely not least, I think all of us are so challenged by the issue of pain management in our patient population. And how do we avoid drug addiction? How do we avoid constipation? There are just so many issues to pain management that affect our patients every day. And so we're very grateful that Mercedes Rodriguez Solin is going to speak to us now about pain management.
Thank you.
There you go.
Well, thank you so much to the OIF for the invitation. No, little higher. Thank you. Well, thank you so much for the OIF for this opportunity. I am really glad to share with you some challenges in pain management in OI. I enjoy a lot the discussion that it happened yesterday, and I think like along all this conference about pain. And we call this presentation the elephant in the room. What more can we do? I have no conflicts of interest, and the agenda for today, first of all, we will start speaking about the elephant, and second step is why are we focusing on pain? The next question is what more can we do? And then I will share some challenges in pain management. So I start with the elephant in the room because the International Association for the Study of Pain has defined pain as an unpleasant sensory and emotional experience that can be associated with actual or potential tissue damage. But then they decide to expand this definition and to include other things that I think that they are important, because we need to always keep in mind that pain is a personal experience and that is influenced by many, many factors, and that pain and nociception are different phenomena, and also that each individual learns about pain through their own experience, and that any report of pain should be respected, and that also pain is, we want to treat pain not only because of treating pain, but because it is associated with adverse reactions such as affecting function, social and psychosocial well-being. So what does the elephant in the room means? And this means when everybody knows about something, but no one is talking about it. And the more the elephant is ignored, the bigger it grows. And there are many reasons for this to happen, but the number one reason is the fear or not wanting to handle this situation. So the first thing we need to do to handle this situation is to start thinking about this, and we are doing that to get ideas from team members, and I think we are also doing that. So we will be ready to do a step forward, because most elephants, if they don't go away alone, so we need to do something with them, because if not, they will find a home and stay longer and longer there, and we don't want that. But why do individuals or parents avoid the pain issue? And it has been reported in OI that parents find distressing to see their child in pain, and this is logical, and found that it's challenging for them to treat the pain, the fatigue, and the tiredness that their children may have. And also it has been described the relation between child and parents coping is complex, and children may hide their pain to help their parents and make up for causing them pain and frustration. And also individuals we know I have reported that sometimes they are conflicted between living with pain and having the adverse reactions of the different drugs, for example, with constipation and diarrhea that these type of medications may bring. But why we avoid the pain issue, and why physicians or the rest of the team members may avoid this issue. And we know that pain might be complex sometimes and multifactorial and may change over time. So it's a lot. And sometimes we don't understand what is happening, why, what are the causes of pain. And sometimes we can't fix this quickly. And as physicians, usually we want to fix things, and if it's quickly, the better. So we need a team, and well, that's another thing. And sometimes different types of pain overlap. So it's complicated. And even though if we want to assess pain, to assess pain in children and in adults, we need different tools, and to assess acute and chronic pain, we need different tools. So it could be distressing for all of us. And when we start treating our patients, we may need different treatments for different patients. And even though if we do everything, we know that residual persistent pain exists in our patients. So all of these are some of the reasons that we might avoid this topic. But why are we focusing on pain in this conference? And this is because in OI, pain has not only been described as an unpleasant situation or experience, but also as disabling, because pain has the potential of affecting quality of life directly or indirectly by affecting mobility, participation. And in our multi-center study of pain that I will share some results with you today, even though it's still under review, we found that pain affect mobility, and individuals with chronic pain perform worst in all the mobility outcomes we evaluated. And also we found that participants with chronic pain have their participation is also affected, and they have limitations in their participation activities, and they have an increased number of days per year that they miss from school or work. Sorry. And also we want to speak about pain because when we take into account patients' perspective, sorry, pain has been cited as an ever-present burden in their life, and also living with pain impacts their sleep and mental health. So it's an important issue. And also patients has referred that they are concerned that if they have a microfracture that we can't evidence in an X-ray, we might not treat it, even though this may cause pain and disability. And also in our multi-center study, we found that when we analyze the expectations for treatment, we found that having pain relief ranked highest in the expectations of patients' treatment, as you can see here in this table. So having pain relief was higher than being able to do more at school, to do more sports, and to look better, among others things that we ask patients and their parents. And we are also focusing on pain because you all know that OI has many possibilities of having pain because it has many different causes, and usually this makes that pain in OI is complex and it's multifactorial, so one factor interact with the other, and treating this is complex, and that's why we are trying to address this. And also because in our multi-center study, we found that this is a prevalent situation, chronic pain. We found that almost 42% of the participants reported having chronic pain, and that this problem was similar across the different OI types without a significant difference. So what more can we do? And that's the big question for today. And I don't have a big answer, but going through the literature, the experience, and our research, I made a list of some things that we might do. And the first thing is that we need to address pain, to assess pain. Starting for knowing if our patients have pain or not. Second thing, if we might try to interfere with the chronic pain cycle, and we will speak about this later. We need to be aware of the factors that are associated with chronic pain. We also need to promote and maintain physical conditioning, and in many patients, also working on positioning and orthotics will help. But overall, we need to work with a multidisciplinary approach, and we spoke about this the whole day today and yesterday. So first thing is the medical history, as always, and a physical examination, because this could give us the answer, and we don't want to miss treatable causes of pain. And so when we start with pain assessment, the tool that we found that it was most commonly used was the visual analog scale of faces, depending the age of the patient. And this scale is good, but is a better scale for acute pain than for chronic pain. But it only takes seconds to use, and is good if you want to have some information about response to treatment. So it's a good tool, but we will try to use multidimensional tools because we know that pain is complex and it's a multidimensional experience. So we having all this information, we will be able to understand better where is our patient and what we need to do. So I brought some that's the next slide. So which tool should we use? And this is a big question too, because there are many tools out there, and we learned that there are no perfect questionnaires, that there is no one questionnaire that fits all the needs, because there are different types of pain and different ages of the patients. And also we may have different objectives. It's not the same, the tool that you are going to use if you are doing research than if you want to evaluate clinical response. But we should use scales that are developmentally appropriate. We need to try to use validated tools, multidimensional tools, but overall we need to be consistent in pain evaluation. This means always evaluate pain, even though the patient might not bring this, we need to ask. So now, yes, I brought some tools that I like, that I select, basically based on that these tools are multidimensional and they have been validated, and some of them have been validated in OI, as is the case of the APPT, that is the adolescent pediatric pain tool for multidimensional measurement of pain. And as you can see in one sheet, you can evaluate the location of pain. It also has a scale to measure intensity and descriptors of pain. So with this, you will be able to understand better patients' pain, but of course, it can only be used in children and adolescents. The next tool that I brought is another tool that has been validated for OI that everybody knows. The promise and the good thing is that you can use it across lifespan, and in adult measure pain behavior and pain interference, and in children it measure pain interference. A tool that I think is useful for adults is the pain quality assessment scale, because it has been recommended by the impact and measure intensity, pain descriptor, types of pain. It doesn't give information about location. All the tools have something that they don't measure, but it seems to be a good tool. It includes almost 30 questions, so it could take some time. And the last tool that I brought is the POTSI. POTSI is not a tool to measure pain, but with POTSI, you can evaluate limitations to activities, participation, pain interference, and pain intensity. Another methodology that has been described is the pain diaries, and these methods could be useful to try to understand pain and its fluctuation and to capture real-time data and to track acute pain across with chronic pain, because we know that they might overlap. So moving to the next, when we assess pain, the next step that we are suggesting today is to interfere with the chronic pain cycle. I brought here two different cycles that I like. One was proposed by Mueller in 2018, and you know about this vicious cycle where fracture and pain and the conditioning and fear act in a patient with OI, and we know this, but pain is important. But I also like this cycle proposed by Boyce in 2021, where pain has a center place, and is related with progressive deconditioning, but also with depression and social avoidance, because it also includes all the psychosocial aspects that might be related with pain. So we need to try to interfere with this cycle, because this goes on and on. So what can we do to interfere with this chronic pain cycle? The first thing is to try to treat acute pain. Treating acute pain could be better, easier, and you could have better results, and avoid the physical deconditioning secondary to pain. Promote mental health. We know that participation is something big and important for all of our patients, and that sometimes fear may interfere with this. Also, psychological interventions to reduce chronic pain has shown evidence, and there is a Cochrane review that shows that children and adolescents that use this type of therapies, that they have chronic pain or headaches or other types of pain, maybe benefit from these types of interventions. And that's why I brought two examples today, CBT and family therapy. We know that CBT may increase personal sense of control over pain and also help the acceptance of pain. And family therapy, everybody knows that OI doesn't affect only the patient, but also the family. So maybe it will help to identify family dynamics that contribute to pain and to interfere with coping strategies that the patients may develop. So, and will also help, I want to remark this, to increase the awareness between in the relation between pain, fatigue, and psychosocial issues, and treat contributors to pain such as anxiety and depression. So the next step is to be aware of the factors associated with pain. We know that knowing the factors that are associated, maybe we can prevent, or we can be, have a high suspicious if our patient has these risk factors. And well, the first thing is age. We can't change that, but we saw that the frequency of chronic pain increased significantly with age, as you can see in this graph. This table is kind of easy, but what we did, we tried to see what were the factors, the variables associated with chronic pain, and we found, I only brought today the significant association associated with chronic pain, and you can see that age, being female, having Medicaid insurance, having a positive history of rodding surgery and scoliosis, using wheelchair and assisted devices, having other medical problems. We were speaking about that this morning, having a high weight and high BMI or a low height has been associated with having chronic pain. So maybe taking into account health and weight, and in general, we can take care and prevent these types of predisposition or risk factor for chronic pain. So I spoke about this yesterday, the different predictor factors and protective factors that we found for chronic pain. So we know that this is related. If we can do something with this, maybe we can affect the outcome. The next step, the next suggestion is to maintain physical conditioning. Everybody agree that one of the most important treatment in OI is the physical therapy, the movement, the exercise. And we know that this could reduce the muscle-related pain. And also it's important to try to find the right amount of exercise, because it has been described that overdoing could be associated with pain, but in many cases, usually not doing enough could also be associated with pain. So we need to ask if we need to modify the activity level of our patients. And as we always say, avoid prolonging mobilization and treat pain, because this will be the reason that they are not participating in physical activity. The next topic is positioning and orthotics. And we want to speak about this because we found that back pain was the more frequent location across all different OI types. So we think that positioning may play a role there, and we speak about this. And also we found that foot pain was important, especially and prevalent in OI type 1. Yesterday we spoke about this too. And especially we found an association between foot pain and the patients that walk or use assisted device. And in the contrast, the patients that use wheelchair, they have less foot pain. So we know that we should consider orthotics to maximize mobility and to optimize muscle function, but also to minimize symptoms of pain and fatigue. And we know that hypermobile, painful, and deformed feet could benefit from shoe orthotics, shoe inserts, supramalleolar orthosis. I brought some of the examples that we use at trainers. But we also know that we need to keep this at the minimal amount of orthosis, and that the material should light for our patients. So preventive positioning is something that we need to work on. Strengthening the trunk muscles will bring many benefits to our patients, and also changing positions will help prevent contractures and deformities that can limit mobility and can increase pain. So we need to work with physical therapies, with physiatry, and any patient that is using an assisted device, wheelchair, and they will help us also assessing the need of orthosis, braces, and also finding the appropriate size of the assisted device, or the need of customizing them according to the needs of the patient. So all these, having a better position, could benefit our patients. And the last step is to work in a multidisciplinary approach. It seems like Dr. Tosi and me choose the same image. We don't want to be like those scientists, blind scientists that only have some information of the animal. We want to have the whole picture, and so for that we need to work together, so we don't reach to limited conclusions, and we can offer better opportunities to our patients. Unfortunately, there are not enough evidence to recommend pain treatment, and there are no clinical guidelines on pain in OI. So I will delineate only general concepts, and everybody agree that it's important to know the etiology of pain, to know which is the cause of pain, but we need to keep in mind that especially in mild or moderate cases of chronic pain, we will not find this easily. So we need to treat pain while we are addressing the underlying causes. So that's a concept. Another concept is that a simple intervention may not be able to solve a problem that a long-standing pain event. So we need to have a broad approach to pain, to work with a multimodal pain approach. And it has been published that the synergy brings better results using different approaches together in the same patient. So we know that our patients may benefit from surgery, pharmacotherapy, psychology, physical therapy, occupational therapy, physiatry, and many others at the same time. And with that, we may have better results. So of course, for this, we need to work in a multidisciplinary team, especially when we are working with chronic pain. And sometimes we need to add a pain specialist, and there are cases where we really need this, especially if we need to address persistent pain, complex pain, neuropathic pain, in the cases that the patients are using opioids or other adjuvant medication, for example, some patients or patients that are using cannabis. And I will remark once more that we need to include also in our team the psychologists and psychiatry, depending the case. They will help the patient, and they will help us to understand factors associated with the chronification of pain and also factors involved in resilience. So, and they will help us also to detect and treat depression and anxiety associated with pain. So everybody knows about the WHO analgesic recommendations, and the big things that they say is go by the clock or around the clock and no on demand to prevent the patient reaching pain until it's treated. And the other thing is to go by the ladder to start with non-opioid and then to increase to opioid. We know that opioids, they have a room in the treatment of pain, but we try to keep us away, to keep our patients away from opioids, and we have reasons for that. We know about the misuse of opioids. We know also that opioids are related with the chronification of pain, so they can help the transition between acute to chronic pain. But we know that after a surgery or after multiple fractures, we may need to use this type of medication. So that's why I like more the other ladder that I brought here, that is a modified WHO ladder that put one step more. And the good thing is that they suggest to include integrative therapies, integrative medicine since the first step. And this is good because the original ladder was designed for patients with cancer, and we are not treating this type of patients. So these integrative therapies will reduce or even stop the use of opioids analgesics, and this may be a key factor in mitigating the opioid epidemic. And they also include in these steps the interventional therapies such as epidural injections or neuromodulation. So what I am showing here is the table where we included all the treatments that the patients referred they were using. I classify classical therapies, this one the ones that we asked the patient if they were receiving, and the other ones were the non-classical therapies, because we asked them also, are you receiving anything else? And the anything else was big. We found that almost 40% of the participants refer receiving other treatments, as you can see here: Tylenol, heat pad, hydrotherapy, cold pad, cannabis, stretching, and then the others that I summary like others, but you see the percentage is important. And in these others therapies, patients are using muscle relaxants, gabapentin, orthosis, acupuncture, distraction, relaxation, aromatherapy, well, many different treatments. And these are the non-classical treatment that our patients are already using. So they are already using integrative medicine. And these graphs show, as I said yesterday, the patients are not using one treatment. The median number was 2, but this goes up to 7 different treatments. And most of the participants combine pharmacological and non-pharmacological treatment. This is what we found. And as you can see in the graphs here, the most common combination was between NSAIDs and physical therapy, followed by NSAID, bisphosphonates, and physical therapy. But there are some patients that they require everything, and they need to mix everything to have pain relief. So multidimensional and multidisciplinary approach. So we spoke about a lot of tools that we have to treat pain. Yesterday, today, surgery, bisphosphonate, physical therapy, orthosis, many of them NSAIDs, and we are speaking about psychotherapy and many other procedures. So we need to see which combination our patient need, and this will be very individualized, and we will choose, of course, taking into account patient's perspective, but also with the help of the team members to see what would be more beneficial for our patients. So the last point, I will share with you a couple of challenges that we have at Shriners Hospital, a couple of cases, and also a comment on adults. So the clinical scenarios I brought today is a patient with a pain localized in tibia, and another patient with complex pain, and a comment on adults. So our patient, 17-year-old male with OI type 4, He had a non-union fracture of the right tibia, as you can see in X-ray. He was suffering with pain. This pain was disabling. He stopped walking. So we needed a multidisciplinary approach. And of course, first thing, the rod needed to be revised, the rod and the plate to improve fixation, and also bone graft was used. And when he was ready to start standing, AFO with anterior panel helped him to give him more support and feel more safe and with pain. And when he was ready, he started doing hydrotherapy to strengthen his muscles. And when he was ready, he was able to start using a walker, and he was under bisphosphonate. And we were lucky because he said, I'm good, I feel strong, and everything is good. And this is an example of multidisciplinary approach where we have a good result. But we know that that's not always the case, and patients are different. And here I am bringing another case. It's a girl with a complex pain, 18-year-old with OI type 3, and you can see that she has scoliosis that require posterior spinal fusion. She uses wheelchair, long history of multiple side pains, especially in hip areas and low back pain, migraine headaches, chronic migraine headaches, recurrent abdominal pain, recurrent vomiting, irritable bowel. So many diagnoses, and this is a real case of complex pain when they associate all these type of symptoms. And you can see the list of things that we needed to do is long. And so we required the help of nutrition, neurology, social worker, of course, surgeon, bisphosphonate bracing, exercise stretching. So we tried to do everything. She tried different medications. Some of them produce gastritis. We have to take them. So complicated case, and she really benefited in this case to using a pain clinic. And in that pain clinic that she went, they use acupuncture, Valium, medical cannabis, intensive behavioral modification program. So she really needs a lot. And with that, she reported that her pain moved from an 8 to a 4. So of course we are afraid of polypharmacy, and of course we are, she still has persistent residual pain. So not all cases are simple. That's why we are discussing this topic, and not all, we don't have the results we expect in some cases. Only a little line about cannabis, because I know that this is a big topic, but unfortunately there is limited evidence and experience. I have limited experience about this, and most of the reports that I have found, as it was said yesterday, they are anecdotal. And what our suggestion is to involve a pain medicine specialist in these cases where the patients are using this or they require to use this, so they can help us a little better with this. And the last thing I will share with you is a comment about adults. I am a pediatrician, so I was not aware about this situation, but going through the literature and also listening to adults in conferences and also analyzing the results of our multi-center study, as you can see in this graph. Well, maybe it's very small and you can see, but yellow and blue represent moderate and severe pain interference, and orange represent no interference. So you can see how with age, no interference decrease and moderate and severe pain interference increase, so significantly. So it seems like adults are dealing with this in a daily basis. And we also need to be aware that, and this was said yesterday too, that adults usually have limited access to multidisciplinary teams specialized in OI. So we need to increase awareness of the pain situation for the adults patients with OI, and we need to generate sources of information and to collaborate in building networks, trying to help and to address in this topic. So to conclude, I think that everybody here agree that pain should be addressed and understood, that chronic pain management could be complex, that we need to work with a multidimensional mind and a multidisciplinary approach, that adults require special attention, and that guidelines for treating pain could be useful. And I know that OIF and OIF Europe are starting to to see if this is possible after hearing today to Dr. Sandhaus. I don't know if call them guidelines or recommendations or informal recommendations, but if possible, if working together, we can have a guideline of where to go. I think it could be helpful. So with this, I finish, but I am open to comments and questions. Thank you for the Brittle Bone for supporting our multi-center study of pain. Thank you to my mentors, Dr. Smith and Dr. Harris, and to the whole multidisciplinary team at Shriners Hospital, Chicago.
Thank you very much. What an incredibly comprehensive presentation. Do we have questions? Everybody's getting fanny fatigue, I fear. I think this is going to be a topic that's going to come back over and over and over again, particularly as we move forward in our efforts for providing greater care or better care for our adults. Do we have any questions in the chat? Just checking real quick.
Nope.
Okay.
Where is she? Where did she go? Oh, there you go. Somebody mentioned yesterday taking antidepressants, and I know Sharon, I think you commented on that as well. I didn't see that on the list anywhere. Was that something that is a strategy or for anxiety and maybe to help with pain?
Yes, what
Thank you. Yes, what we mentioned in the presentation is that we need to address depression and anxiety because they are cofactors and they predispose to chronic pain. So the first thing is to address and then to treat, of course. And for that, we will need the help of psychology and psychiatry to help us. And that will benefit the chronic pain situation. Yeah.
Oh, and I just wanted to maybe follow up on that. Any experience in your data looking at duloxetine? I mean, that is a Cymbalta, an SNRI, FDA approved for chronic pain in certain situations. And, you know, something that I commonly see several of my adult OI patients on who have chronic pain.
Yes, no, it was not mentioned. All the treatments that I showed today, I showed them because they were used by more than 5 patients in the analysis. Maybe they were less than 5, and I don't remember now, but they were not used by many patients at least.
Okay, so I have 2 questions. They're also probably a little non-sciencey, but is there a fear or a concern that if a patient feels like their pain is not being addressed, that they may move to some unsafe ways of addressing their pain, like getting opioids not through a pharmacy, but like on the street? We hear so much about overdoses and fentanyl, which is, I don't consider really an overdose. I think it's more of a poisoning, but that's a whole other story. But so the fear of the pain not being addressed and patients taking that into their own hands. And then I noticed on one of your slides, you mentioned nutrition. So are you also focusing on like weight management as a way to help maybe reduce or limit some of the chronic pain?
Okay, good questions. For the first one, I don't have answer. Of course, I can imagine that if someone is living with pain and it just feel like he is being addressed, these things may happen. And one thing that has been shown is that in the epidemic of opioids, the musculoskeletal conditions were the ones that bring this high. So that's why we need to try to use other types of medications. So musculoskeletal pain is one of the important factors in the prescription in this epidemic, and that's why we are trying to move away from that. So that's the first thing. And then the second question was weight management. Well, that's super interesting, and I really think that nutrition should be always a part of the team, preventing at least. And in the cases where overweight or obesity is present, with more reason, we found that high weight, high BMI are associated with the presence of chronic pain. And this is not only in OI, but in many other conditions such as osteoarthritis and many other conditions. So it's important to maintain a healthy weight. Yes.
Hi, we have a question from the chat. Someone was asking, do you know of anyone using teriparatide or anti-sclerostin AB for pain?
Okay, good question. Thank you. Yes, we have in the database patients using both medications, teriparatide more than anti-sclerostin, but the patients didn't report it using it for pain. So that's maybe something related with the questionnaire and not with how the patients are using it. But yes, I think that's something to be explored.
Thank you.
No problem.
I had one more question. So we know that pain and fatigue are so tightly wound together in adult patients that have chronic pain. In your data, was there an exploration of fatigue or any outcomes that could be drawn to correlate the two?
Okay, yes, thank you. Yes, in the literature they are super related, pain and fatigue, and there is one study of ARPONEM, a new study that shows this. And also there is another tool that evaluates both of them that is called STEMS, and I like it because it's very easy to use and you can evaluate these symptoms that are associated with disability. But we don't have that in the questionnaire so far about fatigue. We are not asking, or at the moment I analyze the data, at least we were not asking about that, so I can't answer. I'm sorry.
We have another question from the chat here, and I apologize for how I'm going to pronounce this because I don't really know. Someone is Ingen is asking, what about amitriptyline in low dose for muscular pain?
Sorry, can you say that again?
amitriptyline, line, LINE. It's also over there on the screen.
Okay, yes, thank you. Well, yes, amitriptyline has been suggested as a second-line treatment for neuropathic pain. First line, gabapentin with less adverse reactions. Second line, amitriptyline.
Great. Do we have any additional questions? Thank you for that important discussion.
Thank you.
I fear it's growing and growing. I think the one thing that you were more polite about, perhaps, than I might have been, is the use of cannabis. It is interesting. Patients don't want to tell me, maybe because they think I'm an old poop and I'll get mad at them. I don't know, but certainly sometimes we have to close doors because the smell of cannabis on the clothing is so thick in the clinics, and it's an odd thing in a children's hospital, but it's certainly taking over to a certain extent some of the self-medication elements, and it'll be interesting to follow up on it. It's interesting to note that the FDA is actually going to be doing a big thing in the next few weeks about oral presentations, because there have been so many overdose issues, and how the hell do you keep everyone safe if they're taking oral? So that is an issue. All righty. So our final topic, thank you, is much more loosey-goosey. Thank you for being here. We really, this is just a look to the future, a chat. Our first 3 town halls by American rules. We're all done virtually. It is so great to see you personally. I know that my own hospital hates for me to be away because then I'm not in the OR. As we look to the future, our sort of plan, but we would love some feedback, is that we will continue to do this twice a year. Hopefully, we can continue to raise the money to do it in person once a year to try to be sure, if we possibly can, that there is a representative from each of the clinics on our website. Because if we don't communicate with each other, we're certainly not going to communicate well with the patients. And then have the middle of the year meeting be on Zoom, because then you don't have to travel. Always an advantage, particularly given the airlines today. But I'd love folks to just give us some feedback here, please. We worked hard to make this happen, and we want to know what topics would you have liked to have, timing, anything you want to complain about. We're eager to hear. There must be someone who has something to say. Are you going to embarrass me? Thank you. Whoops, you got 2. All right.
One topic I'd really like discussed, I had emailed a lot of the groups probably last year, was acute pain management, for patients that fracture at home. Some clinics will give small amounts of Valium or pain medicine for families to have for fractures at home, so that the parents, feel like they can splint them and treat them till they can get them to their doctor. So I'd love for there to be a discussion about what each center is doing, because everybody does things differently. But that's always a big request and a big question for my families. And I don't have a good answer for them because I'm not experienced in pain management.
Great idea and a good opportunity for a roundtable, because I'm sure we all do it differently.
Well, I mentioned to you, I'm very grateful for the opportunity to be here. So thank you to you and the OI Foundation for making it possible. One subject I'm interested in is about mental health and depression, specifically to the OI youth, and risk for suicide. That's been a hot topic. So wonder if there's any data, statistics around that.
I don't think there's a lot, but I certainly think, again, it's potentially an opportunity for a roundtable. Yeah, because absolutely. And I find my teenage boys are my biggest risk group. They're really realizing that they're not going to grow up to be Superman, no how. And, I'm the little old white lady, and I come in and what do I have to offer? And how we can make sure that the kids get the support that they need, I think is really important. Thank you. Others? This means we're going to put you on various committees. Yes, ma'am.
Thank you. I'd also like to thank the OI Foundation for
Please
sponsoring this
introduce
event.
yourself
Oh,
again.
absolutely. I'm Shelley Brandstetter. I'm a nurse practitioner at Seattle Children's Hospital.
Great.
And I'm a newer OI provider, and I really appreciate the opportunity to learn from everyone. I'm wondering if there's any sort of guidance around activity management. I have so many patients whose school physical therapists are asking specific questions around range of motion and that sort of thing. And I would love more information about physical activity and keeping kids active and healthy. I also have a lot of parents who are terrified of letting their kids break. And so I have some kids who are really late ambulators because parents are so afraid of having a fracture. And we know that that is really damaging developmentally as well. So just maybe a little more guidance.
We actually are very lucky in that there are a number of physical therapists who spend a lot of time thinking about OI. And we'd love to have them be speakers at the next go round, so to speak. Absolutely. I have a question to the group. So one of the topics that comes up when I meet with adults all the time is GI. Often diverticulosis, constipation being the leading problems. Is that something that you are seeing, and has anybody found a GI person that's willing to study this problem? No comments? Yes, sir.
And the kids with the more severe forms, I think if you don't find that they have rocks in their bellies, that's very unusual. And I think it's very early. We only had a gastroenterologist in our clinic for about a year. They're still putting it together. So I'm not sure if anybody around the country has really looked at it, but it's a real issue. I know Megan published her 2 on the kids that had colostomies, and that sounds like a horrible, awful operation, but those parents reported that that's the biggest impact on their child's health and well-being in years. Yeah, the first time that one child started putting on weight, he was just nothing to him because he's chronically constipated. So it really is a topic I think we need to work and develop on.
Good.
We have a question from Ingan. If you'd like to unmute yourself and ask the question, you're welcome to.
Yes, the question was maybe a topic could be hypermobility and soft tissue like ruptures, tendons. I don't know if that has been a topic before, because I think this is a big problem for many, also causing pain. So.
Thank you. Yes, I think we're seeing that more and more as our adult population particularly gains greater voice. And for those of you who weren't here yesterday, I guess we didn't record it. So we'll make Jeanne Franzone come back. We'll get you next go round, because really she gave an extraordinarily intelligent presentation on this issue where we have virtually no data, but I have had 2 teenagers this past year have devastating patellar dislocations. And so I'm totally sympathetic to this issue. And I think, again, we've always been so used to talking about long bones that moving on to tendons and ligaments is an important next step. Yes, Jeanne.
Again, thank you for bringing that up. The fact that you bring that up highlights it as a really important issue. What would be, especially with all of, your tremendously large organization, really pulling from so many parts of the world, what would be the most helpful way to incorporate that into an event? And what would you highlight as the biggest issues in that field?
Actually, we tried it in 2015. We had a topical meeting about soft tissue, but the problem is that there is hardly any research or knowledge about this, so there's nobody to invite to speak about it. So it was more a meeting to gather ideas about what the problems and challenges are. So yeah, I think we will have some data from the impact survey on this about how big the problem is. So maybe we could use that to create some hypothesis for project. And I also think we see hip and knee replacement. There's more and more questions about this in the different groups. So something about joints and arthritis as well, I think.
You're here. Good. Frank.
Well, it's maybe not a topic for discussion for this meeting, but maybe for research or collecting data. I think one issue in adults with OI is fragility of vessels. So arteries that just pop for no reason. And I have not seen any data on that. But I had 2 doctors working with us that had OI, and one had intracerebral bleeding while she was working with us, and the other had intrapleural bleeding. So I just wonder how important that issue is. It's I've heard that anecdotally from a few others, but I have not seen any collection of cases or data on that.
That might be a place where the registry would be helpful, because we could, so to speak, advertise that that's a question and do the technique that Deb Krakow has done, which is, may we reach out to you? Are you willing to give us your name? Because finding those patients might help us get a better handle on what the questions are. Pardon? Right, that's also true.
Well, no, I don't mean to be, I'm not trying to be facetious, but Frank, we have some, a case like that too, and the person unfortunately died from the episode.
Interesting. I mean, I'm totally unaware, but in my own clinic this week, I had a 36-year-old woman come in who was blind, and she had had bilateral retinal detachments as a teenager. I've never heard of that, seen that. Is that OI related, or did she have, 2 strikes against her? I think these are where some of the, hopefully, if we can get the community that is in the registry to respond, we can start to identify at least some of these patients, clearly not the dead, and start to figure out what the questions need to be and what we potentially can do for prevention. Absolutely. All right. Oops. Yes, ma'am.
I apologize if this was addressed in the second half of yesterday.
Oh, that's okay, but please introduce yourself.
Oh, sorry. I'm Catherine Dawson from Kaiser Permanente. I'm a geneticist. And I missed the second half of yesterday because I was in flight. But the question is about the optimal bisphosphonate therapy and differences. And at the very beginning, I know somebody was saying something that there was maybe better effects from the pamidronate more than the zolendronate. And I know that we'd moved to zolendronate for a lot of our patients because of just the ease and the decreased frequency of having to disrupt your life. And so I would be fascinated to understand if there's actual, movement and clear recommendations for one versus another type, the oral versus non, and also ages. And anyway, that would be really interesting.
I have to warn you that just like HRT, the second place where there's a lot of controversy is bisphosphonate. But you raise an important point. I mean, we all sort of have been running our little programs and have our little prejudices, and maybe it's time to air the differences and speak to the differences. I think that would be great. Yes, sir.
So 2 things. One thing is we're using all these bisphosphonates, off label. So it would be interesting to see if we could get somebody to actually sponsor some research to actually answer these questions. And I don't know if any of the drug companies are interested, because we're a small population compared to the osteoporotic, groups where they did all these studies. So, that gets very complicated. The other thing I want to find out, I recommend to any kid over about 10, 11 years old to look with their parents to look into mindfulness stress reduction therapy as a means of dealing with their pain. With some of the work that came out of the University of Massachusetts in the mid 90s, I think, with John Kabat-Zinn and such, they showed that mindfulness meditation can help any source of pain. About 65% of people respond and get remarkable relief from their pain. So I think it would be interesting to bring somebody who knows more about mindfulness to talk to us at some point.
We could do that. We definitely can do that. All righty, it's Friday afternoon. I'm sure you all want to get back to your families. It's just been grand to have you here, and we look forward hopefully to making this happen again next year. Thank you very, very much.